हाँ मैम सब रेडी है 9:45 तक हो जाएगा।
सब मीटिंग लाइव स्ट्रीम होने लगी है यूट्यूब पे।
यस अभी जस्ट मैंने स्टार्ट किया है। ओके तुम्हारा बैकग्राउंड नहीं आ रहा है ऋषभ, तुम्हारा बैकग्राउंड नहीं आ रहा है।
यस सर।
हेलो।
यस सर।
हाँ सर वो एक्चुअली मेरे
तो कर रहे हैं ना
अगर बोलते हैं तो ऋषभ हेलो सुरभि।
यस सर।
मैंने रिकॉर्डिंग अलाउ किया है तुम्हारे आईडी पे, तो रिकॉर्ड करना सेशन, ठीक है? ओके
यस सर।
hello everyone. We'll wait for some time. Let everybody join.
Good morning, Achin. Hi, Satish.
Good morning, ma'am.
Good morning. Prasad sir haven't joined. Hi, Sandy.
Hello.
Hi, Abhilasha ma'am.
अरे संतोष सर, अभिलाषा मैम,
Good morning.
जस्ट तुम लोग मिलने के लिए मैंने ऑन किया ऑडियो वीडियो।
अरे क्या बात है सर, क्या बात है।
It's strict instruction from the Achin. Good. All the best सबको।
थैंक यू सर, थैंक यू।
Thank you.
We are eager to listen to you people. काफी सारे लोग हैं।
Hopefully, we will stand by your expectations, Santosh.
No, I know you'll do it better. Besides patents and all, I have seen your name.
Good morning, everyone. We are just waiting for Dr. Prasad to join. He was unable to join. Our respected Dean ma'am has joined the meeting. Okay, I think everybody has joined now. Prasad sir has also joined. Rishabh, then we'll start the proceedings.
Yes, sir. Develop a passion for learning and you never cease to grow because an investment in the knowledge always pays the best interest. A warm good morning to respected President Sir, Dean Ma'am, dear guest speakers, staff, seniors, and colleagues. We are filled with great enthusiasm to look around and feel your presence. I, Dr. Rishabh Golcha, along with Dr. Surbi Agrawal, on behalf of Department of Orthodontics and Dentofacial Orthopedics, CTCRI, welcomes you to attend the webinar on interdisciplinary orthodontics. We, with the blessing of Ma Saraswati, would like to start the webinar. First of all, we would like to welcome our respected Dean Mama. She has been a guiding torch, pillar of strength. Her constant motivation and trust in us has played a pivotal role in doing better and upscaling our efficiency. I would like Dean Ma'am to kindly guide us with her word of wisdom.
Good morning, one and all. Respected directors, today's speaker, Dr. Prasad Konda, Dr. Abhilasha Yadav, and I can see Dr. Satish Gupta. Am I right? Huh. So I welcome you all. I welcome all our faculty members, our students, and all the other delegates who have joined from other places. I congratulate Dr. Achin for arranging and coming up with this idea of interdisciplinary orthodontics and arranging this webinar. He collected all three of you, Dr. Abhilasha, Dr. Satish, and Dr. Prasad, and arranged this. So this was a quite and in a very short duration. So this was quite appreciable. I congratulate you, Dr. Achin. I congratulate Department of Orthodontics for arranging this workshop, and I hope this will be of good support. This workshop will be knowledgeable, will provide knowledge, and will be of help to all our students, not only of ortho but of other subjects also. Dr. Abhilasha,
Thank you, ma'am. Thank you so much, ma'am.
I think you will be speaking on perio, no?
No, ma'am. I'll be talking about surgical considerations.
Surgical consideration. And okay, good. So our surgery people also and our perio people will also get benefit from this webinar. I would like our other departments also to arrange such types of webinars so that we others departments also get interest, they take interest, and others also can attend. So that will be beneficial to all our students also, not only of ortho but other subjects also, isn't it? And as Dr. Achin knows, I was always very much like ortho subject always attracted me because it's of like as not because of money, but though I am from oral pathology, not because of money, but my work was good and all that. So, but that time, as you people, you generation are aware nowadays, we were not so aware that days. Like we need to do PG and all that, and this and that, where it was not considered during our days. In fact, people used to just finish their BDS and they used to become gap, never to be seen again in the campus and in the college. So now the scenario has changed. Students are very much ambitious and all that, and I think you all are too junior, all the speakers, so I congratulate you also to achieve such a good level in such a short duration in your life. I once again congratulate and I once again welcome all the speakers and all the delegates, and I give my best wishes to Department of Orthodontics for this webinar. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much, ma'am, for your kind words. Now, we would like to welcome Professor and Head of Department of Orthodontics and Dentofacial Orthopedics, Dr. Achin Chachara, sir, to welcome all to this webinar. Over to you, sir.
A very good morning to one and all. I am pleased to welcome you all for today's webinar session on the topic interdisciplinary orthodontics. We are really thrilled to have you all today with us for this webinar. My heartfelt gratitude to all of you who sincerely are committed to this event. I would like to extend my welcome to all the members of board of directors and respected Dean ma'am, Dr. Hema Suryavanshi ma'am. We are obliged for your presence, ma'am. Today, the task of introducing our guest speaker is a great privilege, and I feel elated to introduce you to them. Today, we don't have one guest speaker, but we have three of them, and they are stalwarts in their fields. They are very well efficient, accomplished, and incomparable. So, Dr. Prasad Konda, Dr. Abhilasha Yadav, and Dr. Satish Gupta. I welcome you all on the behalf of Department of Orthodontics and Dentofacial Orthopedics, CDCRI Rajnandgaon. Let's take a closer look at their alchemy of these three achievers. Starting with Dr. Prasad Konda, sir. Sir has completed his UG from Bharati Vidyapeeth, Pune, and has done his masters in Department of Orthodontics from SPDC Varda. I know him very closely. He was my senior in the college. Sir is now currently professor and head in the Department of Orthodontics and Dental Orthopedics at Al Badr Dental College, Gulbarga, and has expertise in self-ligation bracket system and analysis. We welcome you, sir.
Thank you.
Now, next esteemed speaker is Dr. Abhilasha Yadav. Ma'am has completed her masters in Department of OMS from SPDC Varda, and she was my colleague during that time. I know from that time. Currently, she is professor and head in Department of Oral and Maxillofacial Surgery, our Dental College and Hospital. She has presented around 34 papers in national and international conferences and delivered around 29 guest lectures. She has 23 publications to it and in national and international reputed journals, and is serving as reviewer for reputed journals. She has been awarded with prestigious Jinwala Trophy for Best Scientific Paper at 42 Annual Congress of AOMSI, Nagpur. Scientifically sponsored meeting by European Association for Cranial Maxillofacial Surgery on 17 November 2018. And she is also a receiver of prestigious ICMR Travel Grant in 2013 to present scientific paper at 12th International Congress on Cleft Lip and Palate and related conservation anomalies held in May 2013 in Orlando, Florida, USA. We welcome you, ma'am.
Thank you.
Last but definitely not the least, Dr. Satish Gupta. Satish Gupta has done his master's in periodontics and implantology from SPDC Varda. He trained in sinus elimination technique and management of implants in posterior maxilla. He has diploma in advanced implantology and full mouth rehabilitation, and also has authored a textbook named Immunization Strategies in Periodontal Diseases. He has expertise in full mouth implant rehabilitation and rich and soft tissue augmentation, all are from treatment protocol. I welcome you, Dr. Satish.
Thank you, sir. Thanks a lot.
In the end, I would like to say the capacity to learn is a gift, the ability to learn is a skill, and willingness to learn is a choice. Thank you. Now I will request the host to continue the program.
Thank you so much, sir, for the warm greetings. Without further delay, let's start the session and welcome our first speaker for the day, Dr. Prasad Konda, sir. Sir is a professor and head in the Department of Orthodontics and Dentofacial Orthopedics at Al Badr Dental College, Gulbarga, and have, to his credit, 15 international and national publications. I would like to welcome sir.
Thank you. Will you able to see me?
Yes, sir.
Yes, sir. Am I audible?
Yes, sir. Yes, sir.
Yeah, thank you.
Yeah. Can you able to see the screen? Are you able to see the screen?
Yes, sir, but your presentation is yet to open now.
Okay. Okay. Maybe we'll wait for some time. My
Yes,
presentation.
sure.
Yeah. Now?
No, it's still yet not open. It's taking time, actually. I think it is opening now.
Oh, okay. Is this fine now?
No,
Not
sir.
yet.
Yeah.
We can't see.
Can't see my presentation?
So you need to open it. I think you have not opened it. It's
Yeah,
just.
I opened. I opened and it's there in my. Okay.
Oh.
Now?
Yes,
Yes,
yes.
sir.
Now we can see.
Yeah. Thank you very much for your warm introduction. Thank you, Achint, for organizing such a good webinar with my colleagues, Abhilasha and Satish. A very good morning to you all. So today I'm here to talk on 3 topics. First one, we'll start with orthodontic considerations in ortho-perio relationship. So what is the relationship between orthodontist and a periodontist? I don't know, but we orthodontists, we depend much on a periodontist as well as an endodontist, as well as your prosthodontist and oral surgeon. For example, a periodontist may not be depending on an orthodontist when he is doing cases like flap surgeries or prophylaxis or maybe a little bit of gum surgeries and all.
Thank you very much for
Uh, am I audible?
Thank you, Achin, for organizing such a good webinar with my colleagues,
Hello.
Abhilasha and Satish.
Hello.
Yes, sir. You're audible, sir.
Yeah, there's a light disturbances there.
Okay.
Yeah. So we, as an orthodontist, whenever we are doing a case, we think about periodontal tissues, we think about endodontal tissues, we think about prosthetic relationship, as well as oral surgery issues like extractions or surgeries and all. So we are dependent on all other specialties, rather, I can say. So to cover this small topic, we'll be just doing it under introduction. What are the periodontal responses to orthodontic force application? Benefits of an orthodontic therapy for periodontally involved patient, pre-orthodontic osseous surgery, orthodontic treatment for osseous defects, orthodontic treatment of gingival discrepancies or inflammation or enlargements, minor surgeries which are associated with orthodontic therapy, which a periodontist can perform. The interrelationship between orthodontics and periodontics is often resembles symbiosis. As I said, we are dependent on many of the branches, many of the specialties, rather, I can say. So any specialty's main objective is to restore and maintain the health and integrity of the teeth. Especially in case of your periodontal therapy, they think about the restoration and maintenance of health and integrity of the attachment of the apparatus that is nothing but your periodontium. So when there is a loss of periodontal support, which leads to a pathological tooth migration, when such cases will occur, for example, if you have a proclined teeth, you have a traumatic bite, whenever the patient is biting, there will be a tendency of your lower anteriors hitting onto the palatal surface of your upper anteriors. So which leads to a further proclination, may leads to a bone loss and a gingival support and a bone support, which causes a pathological tooth migration. This is one example I have given you. So many cases, they say that there is an improvement in the bone support and the gingival support with the help of an orthodontic treatment for a periodontally involved case. And at the same time, it may harm the periodontal tissue. So when the application of forces are too high, so that is the reason two-edged sword. So in the picture which is shown as, this is for example, which is shown as upper labial incisor. We have a lip pressure from inside as well as tongue pressure from inside. When these equilibrium disturbs with the help of your too much of occlusal forces, too much of masticated forces, and too much of lower lip pressure and the habits, what exactly is happening? There's the upper anterior is tending to move labial side. There's a reason why there's a pocket formation on the palatal aspects of this tissue. So when there is a palatal aspect, pocket formation is there, there's a chances of increase in the food lodgement, there's a chance of increase in the gingival inflammation, chance of a bone loss will be much high. Various studies have shown that alveolar bone reduce in areas of increased overjet, which I explained just now. Gingival inflammation is generally associated with the crowding. So when there is an irregular teeth, when there is a crowding, when there is an overlapping of the teeth or a rotated teeth, your tooth brushing will not be happening on all labial surfaces or the palatal surface or the lingual surface of the tooth. There will be jumping of the brush. The teeth which are inside, which are palatally placed, will be not cleaned properly, which leads to a gingival inflammation. So many studies have shown that the level of bacteria is higher in the areas of crowded compared to normal teeth. We will see the periodontal response to various kinds of tooth movement. So we all know there are very different types of tooth movements: tipping, intrusion movement, extrusion movement, a translation, or a torquing movement. In case of your tipping movement also, we have something called as controlled tipping and uncontrolled tipping. So controlled tipping is the one, for example, the labial surface of your tooth has to be moved palatally. The root apex will be at a stable position. Only the crown portion will be moved either labially or palatally or lingually, rather I can say. In case of your uncontrolled tipping, which generally occurs with the help of your removable appliances, the application of point of application of force is away from your center of rotation. For example, if you're moving a tooth palatally, a crown is moving palatally, in the opposite direction, the root moves. Similarly, we have different types of tooth movement: intrusion, extrusion. Pure translatory motion is nothing but your bodily movement. So what are the periodontal responses in various kinds of tooth movements? Let us see that. Extrusion movement. So in case of, for example, in the first picture which you have shown, is a traumatic injury which has occurred to the child where the crown has been fractured. In such cases, when you want to restore the tooth, when you want trying to restore the tooth or with the help of a crown, we try to extrude the tooth. When you are trying to extrude the tooth, we give an attachment when it is possible, we'll give a label attachment brackets to the adjacent teeth. We are trying to extrude. So for example, this tooth will have an extrusive forces. Similarly, adjacent teeth will have an intrusive forces. In this picture, we can see the central incisor which got fractured, which has a large root surface area compared to that of your adjacent lateral incisor. There's a tendency of this lateral incisor to intrude when you're trying to extrude the central incisor. In order to avoid such situations, what we are supposed to do, we have to stabilize with the adjacent teeth or make this as an anchor unit and make this segment as an anchor unit and try to extrude. So what are the periodontal advantages can you see when you are trying to extrude such teeth? So if there is a periodontal pocket, infrabony pockets, there's a chances of reduce in the pocket depth or infrabony defects will be seen. So when this deflection is too much, we are not completely engaging the wire like this, but instead we'll pass a wire on the brackets of the adjacent teeth. From here, we try to ligate the tooth with the help of a ligature wire or elastomeric ring. Next comes to the intrusion. Intrusion is a very, I can say that we need to apply very little force because the root surface area, which is at the apex, will be very minimal. So inspire light amount of forces which are beyond the capillary pressures, which will cause a root resorption. So one of the disadvantages is there is a chance of deepening of infrabony pockets, root resorption, and bony defects may increase in case of your intrusion of tooth movement. So your proper care has to be taken for the maintenance of your gum health. Proper care has to be taken for the maintenance of your bone health. The first picture which I have shown is a type of an open bite tendency that is seen in the anterior region because of your extrusion or a supra-eruption of your posterior teeth. So this can be possible with the help of placing a tats on the palatal aspect as well as on the labial aspect and intruding the teeth. Whereas this is a traumatic case, the patient has fallen down, but the teeth has been not completely avulsed, but they are freely in this. In such cases, we need to intrude the teeth. So during the intrusion of such teeth, the amount of forces that we apply should be taken care. Next comes to the bodily movement. As I said, a bodily movement is nothing but your apex of the tooth and the occlusal surface of your tooth will be in the same direction and the same proportion. So in such cases, what will happen? This entire body surface on the pressure side will be resolved, on the tension side will be deposited. Application of your forces which is onto the crown surface has to be managed so that the point of application which is away from the center of rotation should be which is away from the center of rotation, but it depicts that the mechanics has to be made that the center of point of application is at the center of rotation. Then only a bodily type of tooth movement can occur. What are the deleterious effects of your orthodontic forces? What general problems a patient might occur in case of your orthodontic forces? For example, if you see a rotated tooth, this is the first picture, if you see the rotated tooth, when you're trying to derotate a tooth, a premolar, with the help of a couple, the surrounding fibrous tissue or gums tissues will be rotated in the same degree, in the same direction of the way the tooth is moving. If you're applying excessive forces, there's a chances of gingival enlargement that can be seen in the labial aspect or the palatal aspect or the lingual lower on the upper and lower dentition. So when you're trying to give a bite opening wires with the help of nothing but your curve of SPI, which is exaggerated, we give a SPI wire. So when you're trying to correct such a deep bite cases, either with the help of your intrusion of your anteriors or the extrusion of your posteriors, when you're not cinching it back, there's a flaring of your anteriors might occur. So these are the general drawbacks. When the proper care is not taken care, the gingival tissues might affect, either in case of your rotation movements, applying too much of force. In such cases, there might be a chances of your bone loss or recession of your gums might occur in the lower anteriors and the upper anteriors labial aspect. As I said, the development of gingival inflammation during the orthodontic mechanotherapy is associated with different bacterial types. So in case of your, as Hasser said, there's an increase in the plaque index scores, where we can see them. If you see the bacterial conditions, there might be increase in the spirochetes and motile rods. So this part has to be taken care so that they should not be having a proper, they should not be having an inflammation like this. Periodic prophylaxis has to be taken care to reduce the bacterial counts. So we can see the microbiology around the orthodontic bands also. Many of your teachers might have instructed how to band a molar. When you're trying to band a molar, you are giving a contour in the palatal or in the gum area, in the nothing but your call area. The why the contour has been given? Why the contour has been given? Can anyone unmute and answer me? So when you're not contouring the band on the molar, the excess cement which lies between the convex surface, or rather I can say convergence of your molar near the cervical margin, between that and the molar band, the excess cement will irritate the gingiva over here, which causes an inflammation. So this gingival inflammation may be edematous or fibrotic. So when you try to neglect such things over a period of time, you will experience the tooth mobility. You will be thinking that why the molar is slightly mobile, why I have taken proper care of your force applications and all. Your force application is proper, but your bacterial count over there increased, and this causes a gingival inflammation. When there is a gingival inflammation, that is nothing but your attachment for the gingiva to the bone is lost, where further your bone loss or bone support is gone. That is the reason why you see sometimes a tooth mobility in case of your, especially near the molars which you have banded. So in order to avoid such things, what nowadays we are doing it, if the periodontally compromised patients are there, we are doing a bondable attachment or bondable buccal tubes for the molars. Root resorption. So as I told you, for the intrusion, orthodontic force application sometimes causes an excessive resorption of the root. That is nothing but your cementum proceeding to the dentin and eventually shortening the root length. This is nothing but called as a root resorption. So Ketchman in 1927 was the first one to report a case with a severe root resorption associated with the orthodontic tooth movement. When you have an excessive tooth movement, so there is chances of your root resorption. Can you see the radiographically? These are the apexes, which should look even at the end of your treatment. When you apply too much of force, you see the shortening of your root. In such cases, what will happen? The amount of support which is supposed to be there will not be there, and the tendency of your mobility will increase. So in such cases, when cases of your intrusion and torquing, you might experience a tooth root resorption. So according to the classification which is given by Wasserton, so we have different types of classification depending on the severity. So one is your surface resorption, which is involved only in the cemental region. So this is actually a regenerated or remodeled later by itself as nature's phenomena. Dentinal resorption will also reveal repair, and cementum and other layers of dentin will resorb, but repaired along with the morphological alterations. The thing, but you're changing the forces levels or giving some rest, there is a chances of your dental resorption. So when there is a circumferential root resorption, so there is a difficulty in the remodeling of your roots. So that will result in the root actually shortening of the root. So what are the benefits of an orthodontics for a periodontally involved case? Let us see that. So when we come across, can you mute other participants who are, hello? Yeah. When we come across such a case, so this patient has reported for the orthodontic purpose for the space closure and the intrusion of such teeth. So will the orthodontics will help in such cases? Definitely yes. Definitely yes. So in this case, where you have an extruded supra-erupted your incisor because of loss of bone support, and there's a tipping of your tooth in one direction, rather the patient's right side direction. So applying a bracket or orthodontic forces for the intrusion of such things, as I told you, intrusion will decrease the defect of your tooth and will improve the bony support of your such structures. So application of forces should be very light in such cases, taking support of your molars as an anchorage. In such cases, how the orthodontics will help? So if you see the lower arch, we have 3 incisors which have a gingival recession as well as bony support is lost. In such cases, what we are supposed to do is we are supposed to strap up the case. If the case is favorable for the placement of one more incisor, so close the space with the help of your mechanics, create the space for the one lateral incisor which can be placed with the help of your prosthetic implant or fixed partial denture. So this is a case of a growing patient with a crossbite. This is a case of a growing patient with a crossbite. So whenever you see a crossbite, when do we correct it? When do you correct a crossbite?
As and when detected.
Yeah, very good. As and when it is detected, you're supposed to correct the crossbite. So this is not actually a crossbite, it's a developing crossbite. In such cases, your palatally erupted incisor is seen. This will restrict the growth of your maxilla. In such cases, whenever you see with the help of your removable appliances, with the help of your 2x4 appliances or 2x2 appliances, try to jump this bite. Try to jump this bite so that you allow the maxilla or the upper jaw to grow normally as the nature decides. So crossbite has to be corrected whenever you have seen such cases. So when such cases are not detected or not noticed by the parent, what will happen in such cases? When your patient is trying to bite, see this root surface area of your upper incisors will hit the tiny teeth of your lower incisors, which may cause the proclination of your lower incisors, further resorption of your roots of your lower incisors. So whenever a patient comes in a growing age, try to guide the parent so that they should have a checkup every 3 months. I advise in my clinic to have a checkup for a generally up to the age of 12 years for every 3 months. After 12 years, that is nothing but after transition dentition, when the patient is having a permanent dentition once in 6 months is advisable. So what are the advantages we have seen? So as I told you, there's an increase in the bacterial accumulation around the crowded or rotated teeth, or in such cases, when you are trying to brush the teeth, the brush will not reach this incisor which is standing in the lower arch. So in such cases, there is a bacterial accumulation, a plaque formation, and the tartar formation will be there near this. So invariably, there will be definitely a gingival inflammation and bone loss. So aligning crowded or malposed teeth permit the adult patient to better access for the cleaning of your surfaces adequately. So orthodontic therapy also benefits the patient with the severe fracture of your maxillary incisors, anterior tooth, and the forced eruption is needed. Forced eruption is needed for the restoration of this tooth with the help of a crown, as well as to perform any endodontic procedure with the application of your rubber band. So rubber dam. So vertical forces has to be applied very light in such cases where you have a bone loss, osseous defects. So when you're applying a mild forces, mild intrusive forces, there's a tendency for the anteriors to intrude. The bony defects which are seen here will be improved, and the support for the anteriors will be improved. Similarly, orthodontic treatment can improve the aesthetic relationship of maxillary gingival margin levels before the restoration. So when you see the aesthetics or micro aesthetics of your gums, always keep in mind during the case of your orthodontics, your gum level of your maxillary central incisors should be at one level, and it should be equal to that of your canines. When you compared with that of your laterals, they should be slightly coronal compared to that of your centrals and your canines. Many of the postgraduate students where I came across, they'll strap up the case at the time of debonding. For example, this incisor is maybe slightly extruded compared to the adjacent one. So what they'll do is they'll trim this, right? Have you done this, such cases? Many of you will do that. So that to mask from the guide, mask from the HOD or mask from the examiner. So what you'll do is you'll trim that and make the incisors edges at same level. But we are more clever than you. We'll see the gingival margins, how they are placed and how aesthetically you have designed. When you have a cases like this, open gingival margins, it looks very aesthetics, which creates a black triangles like this. In such cases, we can do a slight morphological changes in this incisor region, give an attachment on the labial aspect and the close, and develop a contact surface for the anterior tooth. So when you come across cases where you have an early loss of any tooth, a premolar or early loss of your deciduous tooth, there's a tendency of your posteriors to move mesially. So when your patient wants the replacement of the missing tooth to be placed with the help of an implant, it's difficult for the implant to be placed with the lack of space between the teeth. In such cases, what you are supposed to do is we open up the space, we'll upright the molar with the help of mechanics. In such cases, this cases will also have a slight extruding tendency when you are uprighting the molar. So in such cases, we are supposed to do intrusive mechanics also to be applied simultaneously so that extrusion of the molars should not happen. What are the different periodontal surgeries which are generally required for orthodontic patients? So we come across midline diastema cases very often. So many of us have a doubt whether the diastema is because of your lack of morphological changes or because of your high frenulum attachment. So if it is because of your frenulum attachment, you need to detect a frenum test has to be done, a blanching test has to be done. If the diastema is because of your frenum, generally we advise removal of that frenulum attachment, which is called as a frenectomy. So I recommend, and most of the studies says that closure of that space has to be done before the frenectomy procedure to be carried out. So once the frenectomy done before the closure of the space, because of the secondary healing of this tissue, the closure of space will not happen completely. So frenectomy is nothing but extended into the palatal surface was advocated earlier. Later in 1977, Edwards advised frenotomy. It's nothing but your partial removal or a gentle removal of your frenulum attachment, where your palatal dental papilla, complete dental papilla is not involved. In such cases also proper retention has been advised and observed. Precision. When you have a rotated tooth, as I told you, you have a supracrustal fibers which are very strong. When you derotate the tooth, in a span of 1 day, when you remove the mechanics, there is a tendency for the tooth to take its original position. In order to avoid such rotation of your derotated tooth, what you're supposed to do is nothing but your circumferential supracrustal fibrotomy has been done. A slight blade has to be passed around the tooth to remove the transseptal fibers interdentally, which are entering into the periodontal ligament. So this will retain the rotated tooth in its position. So we come across gingival invagination or gingival enlargement when the application of force. So this is the case where you have an extraction of your first premolar has been done. So you applied too much of force. There's a chances of a cleft formation like this or an enlargement formation like this. So in order to avoid such things, the application of forces should be very light, first thing. Second thing is, when you have the clinical appearance of such invagination is a minor, it's minor one surface crease to deep clefts that extends across the interdental papilla. So forces of application should be minimal. If there's any gingival enlargement has to be noticed. For time being, you remove the force, or time being, you remove the wires and elastics, give some rest to the patient. If still it is not healing, then we can plan for a gingivoplasty or gingivectomy. We can come across gingival enlargement when the application of forces are too much, as I said, or when the application of forces is light, but still the patient is not maintaining the oral hygiene properly. So the cervical margins of your anteriors especially will be looking very anesthetically pleasing. So in such cases, the crown portion, which is supposed to be exposed out, is covered with the help of your inflamed gums. So different techniques has been followed for increasing the aesthetics of the patients. One is your gingivectomy, that is nothing but a removal of your gingival tissues, scooping of your gingival tissues in an architect manner. Intrusion and incisal restoration of your porcelain or with the porcelain laminate veneers if it is needed. Extrusion of the tooth and the fibrotomy and the porcelain crown if it is needed. Later, surgical crown lengthening. If it is really a short, we need to increase the aesthetics of the patient. If the patient is having a gummy smile, then we need to do a lengthening of the crown. Later, with the help of your laminates or veneers has to be placed if it is needed. We can come across hemiseptal defects. How these hemiseptal defects will be helpful or will be helpful in case of your orthodontic treatment. So it may be a one wall or two osseous defects often that are seen around the mesially tipped teeth or teeth which are supraerupted. So these defects can be eliminated with the appropriate orthodontic treatment. As I told you, when you have a mesial tipped tooth, when you try to upright the tooth with the uprighting mechanics, as well as when it is supraerupted, you need to give an intrusion mechanics. Definitely, the osseous defects will improve. So we can come across a bone loss, a different periodontal bone loss, whether it is a horizontal or a vertical. Vertical, we can say one wall, two wall, three wall, or combined. Horizontal bone defects when you come across a horizontal bone defects, if it is much by seeing your orthopentomograph or the CBCT, I recommend first you go for the bone augmentation or flap surgery with the bone grafting. Give a time period of 3 to 6 months time, then you do the orthodontic treatment. So furcation involvement is also plays an important way. This is according to the Glickman's classification is a grade 1, grade 2, and grade 3. Grade 1 and 2 will not have a much of problem, but grade 3 is definitely we are supposed to think about when you're taking an anchorage from such teeth. A Kern et al. Classification, which is given for the defects, irregular bone defects, is one is the craters, trench, and moat. So craters are nothing but involves only one side. These are not much of an not much of significance when you're considering orthodontic mechanics. We can happily carry out your orthodontic mechanics, taking care with the light amount of force you're supposed to apply. When you have a trench or moat, I encourage when there is an involvement of 4 sides. The periodontal restoration has to be done in such defects. Even if that is not possible, we have to think consideration in terms of your extraction of your such teeth, rather than taking an anchorage or rather than giving a orthodontic mechanics for such teeth. As I told you, when you have an advanced horizontal bone loss, what you're supposed to do, we are supposed to calculate the crown to root ratio, which is whether it is favorable or not. So align the crowns may be perpetuate the tooth mobility and significant bone discrepancies can be reduced. In these situations, the crowns of the teeth may require considerable equilibrium. So our main goal is to create the bone support for the tooth. How that is possible? With the help of a flap surgery with a bone grafting. So after grafting, your periodontist will give a pack, and after a span of 1 week, you go for the suture removal. Give a span of 3 to 6 months rest period before applying any forces for such teeth. So as I told you, furcation lesions require special considerations, the most difficult lesions to maintain and can worsen during orthodontic therapy. For example, if you're seeing this furcation involvement, especially in case of your anchored tooth where you have a molar, you're banding those teeth. As I told you, banding should be very proper so that you won't allow any amount of the excess cement, which causes gingival irritation to such structure. Or preferably, you place an bondable attachment or a bondable buccal tube in such cases. So if the patient is with the class 3 furcation defects, which will be undergoing orthodontic treatment, a possible method for treating a furcation is to eliminate it by hemisecting the root and the root of the tooth. So as Sapilno said, there's a different classification for the furcation involvement, class 1, class 2, and class 3. The class 1 is nothing but a furcation with the soft tissue lesions extending to focal level, but with a minor degree of osseous destruction. There's a little amount of bone destruction that can be seen, which is classified as class 1. In case of your class 2, a soft tissue lesion with a variable degree of osseous destruction, but not through and through communication with within the roots. This class 2 again is divided into 4 subgroups rather I can say. Class 2F, class 2L, class 2M, and class 2D. It's nothing but F, L, M, and D stands for facial aspects, lingual aspects, mesial aspect, and distal aspect. Whereas your class 3 furcation with the osseous defects is nothing but your through and through communication. Root proximity. So many of the cases with a relapsed case or else improper orthodontic treatment which has been done, I came across a few cases where your root apexes roots are very much close proximity compared to the crowns. The root parallelism is not maintained. So when you come across in such cases, what you're supposed to do, we are supposed, for example, the patient is required any tat placement or patient is required any further has to be done in the apical region. So you will not have a sufficient space. So the roots of the posterior teeth are in close proximity, for example. So you'll definitely have a compromised periodontal health. So when you have a compromised periodontal health, a compromised accessibility for restoration of the adjacent teeth when you are planning. So in such cases, you require an orthodontic therapy for the roots to move apart. That is nothing but you are making the roots parallel to each other. So bone will be formed between the adjacent roots, definitely if you are giving some time for the healing. So open embrasures beneath the tooth contacts will develop. Additional bone support will be there between the teeth. It will enhance the patient's interproximal area for the maintenance of your interproximal regions with the help of your interdental brushes or of flossing. So it ultimately improves the periodontal health in this area. So in the picture which you are shown is where you have shown as the green site. These are the ideal sites for the placement of your tats. When you're having an area like this in the red color, which is unfavorable, that is nothing but your roots are very much near. There's a chances of your implant to be placed impinging on the roots when you have a less amount of space in such cases. Before starting up such cases where your tats are being planned, first you separate the roots. Separate the root means create the distance between the roots where you are planning for the placement of your tats. We came across many cases like this in the growing patients, fractured tooth, whether it is because of the injury or a sports injury, or maybe if you have a procline teeth, the patient or the child might fall in or something like that, we'll come across. So the child is, as I told you, is a fall or an injury. So this fracture may extend beneath the level of gingival margin and terminate at the level of your alveolar ridge. So what you're supposed to do in such cases when it is terminated nearing the gingival margin? So I recommend just giving an opening a tooth surface where you can attach at least an attach bracket. That much surface has to be exposed out. When giving place an attachment, try to extrude the tooth out. So restoration of the crown has to be done later with the help of your later after the endodontic treatment, as with the help of your rubber dam applications and giving a proper crown. So if the root, the fracture is too much and the root is not sufficiently there, sufficient length is not there which supports the tooth surface, then you need to plan for the extraction of your such fractured tooth. So ultimately it depends on your level of fracture, whether you are extracting or you are erupting such tooth. So what are the 6 criteria determine whether the tooth has to be forcibly erupted or extracted? So one is your root length. As I told you, if the root length is sufficient enough so that it can withstand the occlusal forces later in the life, so then you are trying to erupt the tooth, forcefully erupt the tooth and try to restore the tooth with the help of your processes. Root formation is also important, but it is very slender and all. You think that occlusal forces will not withstand. In such cases, it's better to go for an extraction of such tooth rather than forceful eruption. And level of fracture, of course, is plays an important at what level the fracture has been occurred. Relative importance of such tooth is also plays an important plays an important role, especially aesthetics. If it is an anterior tooth, it's a canine or the lateral incisor, definitely you try to restore, try to erupt and restore it. So endodontic and periodontic prognosis is also must followed. Endodontic and periodontic prognosis must also be taken into consideration. Even if you are having a such tooth like that, you try to consider the root canal therapy for such things. If your periodontic apical lesion is not healed, then you plan for the episectomy and removal of this abscess with the help of your surgeries and all. Try to restore. Even if it is not possible, if you think that the prognosis is not well enough to withstand the occlusal forces and it will there for the lifetime, then you plan for the extraction of such teeth. We'll come across hopeless teeth, maintained teeth come across maintained mainly, especially the crater or lingually tipped. So in such cases, see the bone loss, how much it is there. So if you're giving a proper banding and we have a specific consideration has to be taken where you don't have much of an orthodontic force, such teeth can be taken into consideration for the anchorage. So patients with advanced periodontal disease may have a specific teeth diagnosis as hopeless, which would be extracted before orthodontics. However, these teeth can be useful for orthodontic anchorage if the periodontal inflammation can be controlled. If your periodontal support is there good enough, where the patient is maintaining the hygiene, then there is no mobility of the tooth. Such teeth, which you think is hopeless, can also be taken as an anchor tooth. So what are the different factors which contribute to the ideal gingival form? So as I told you, uneven gingival margins, the relationship of your gingival margins to the 6 maxillary teeth, anterior teeth, plays an important role for the aesthetic of any patient. If you come across such things, I recommend remove the force levels for about some time, do the complete prophylaxis, put them under medication, give rest so that the gingival will shrink enough, will be inflammation will get reduced. Further, even if the gingival margins are not taken at the time of your debonding, you are supposed to plan for the gingivoplasty for the aesthetic purpose. So what are the things we are supposed to consider orthodontic treatment for the gingival discrepancies? Gingival margins of the 2 central incisors should be at same level. As I told you in the last slide, the gingival margins of the central incisor should be positioned more apically than that of your lateral incisor and at this level of your same level at that of your canine. If you see that gingival margin, you have something called as gingival zenith. That is nothing but the highest point. When you compare the long axis of the tooth, the gingival zenith is slightly distal to that of your mesial surface. Slightly distal to that mesial surface. It gives an aesthetic look. The contour of your label gingival margin should mimic the cemento-enamel junction of the teeth. So the papilla should exist between each tooth, and height of the tip of the papilla is usually halfway between the incisal edges. This should halfway between the incisal edges and the gingival height of the contour of the tooth. Can you see this papilla? Can you see this papilla? It should be at the height, half of the height of your incisal edges and the gingival margin. So all these precautions has to be taken in case of your mechanics. We come across open gingival embrasures, maybe because of your tooth morphology, maybe because of your difference in the angulation of the tooth. So what you're supposed to do in such cases, when you just give an attachments or the strap up the case, this you can modify it slightly. Morphological modification within the enamel surface can be done. So this open spaces is usually due to one of the three causes, as I told you. One is the tooth shape, a root angulation, or a periodontal bone loss. The interproximal contact between the maxillary center and the incisors consists of two parts. One is the tooth contact and the papilla. So this has to be, black triangles has to be reduced. When you have a black triangles from in the anterior regions, which look very aesthetically, it's not pleasing. So this modifications has to be done with the help of your orthodontics, taking care or taking support of your periodontal health rather, or maintaining the periodontal health. We have something called as accelerated orthodontics. It's nothing but your corticotomy facilitated orthodontics, and which is also called as periodontally accelerated osteogenesis orthodontics. What exactly we do is, in case of such cases, to speed up the treatment. So we generally move the tooth. We consider it's 1 millimeter per month has to be moved, so that your blood supply and the nerve supply of any tooth should not get disturbed. The patient is recommended, as patient is advisable for the faster tooth movement. The cortical selective alveolar corticotomy has to be done, and particularly the bone grafting to be done, and the application of your orthodontic forces. With this, what can happen is we can move the tooth 2 to 3 times more than compared to the of your normal orthodontic therapy. I can conclude that a magnificent orthodontic treatment can be destroyed by poor periodontal health. If the periodontal, you might be a good orthodontist, but if your periodontal health is not taken care, then your cases will goof up. So hence, evaluation and maintenance of your periodontal health before the treatment and during the treatment and after the treatment is very important. The periodontal health has to be maintained during the process of your complete orthodontic therapy, before as well as after the treatment. Always try to maintain the relationship with the patient. Just deboning the case and sending the patient is not enough in case of your orthodontics. I generally do a follow-up at least for about 3 years in my clinic. I just ask them, come for the routine checkup, get a free prophylaxis done in my clinic once in 6 months, so that I can see how I am improving my orthodontic stability and how the patient is maintaining the periodontal health. That evaluation has to be there for each and every case. Any questions from audience?
Thank you, sir, for an indeed informative lecture. We have feedback form at the end of the webinar. Kindly fill the feedback form. Certificate will be given to those who fill the feedback form. Next up is Dr. Satish Gupta, sir. Sir is MDS in Periodontics and Implantology. Sir has authored textbook named Immunization Strategies in Periodontal Diseases and has done Diploma in Advanced Implantology and Full Mouth Rehabilitation. We welcome you, sir.
Thank you.
Thank you, Prasad sir. We'll take questions at the end of the session, sir. Is it okay, sir?
Yeah, fine. Okay.
Okay, sir.
Yes.
Hello, am I audible?
Yes, you're audible, Satish.
My screen is visible?
Yes, your screen is visible. Just start the slideshow.
Yeah. Is it fine?
Yeah, it's good. It's fine.
Yeah. Very good morning to one and all. Talent wins the game and teamwork and planning wins the championship. I always say this thing. Late 90s में एक मूवी आई थी बॉर्डर, उसका एक डायलॉग सुनाना चाहूंगा सर. हम ही हम है तो क्या हम है, तुम ही तुम हो तो क्या तुम हो. So this dialogue stands very well in this case when we plan for an interdisciplinary approach for any patient, for any treatment plan. When we want a desirable result, we cannot think of alone, we cannot think of an own treatment plan. This is a multidisciplinary approach, and if you deliver it very well, the beautiful and desirable results you can deliver it to the patient. It's very satisfactory to you also. So I always say, I always admire orthodontists, because I always say that the orthodontists are the magicians, because you people play with the tooth positions, and the population which you people work with is like teenagers and the early adulthood. So they are really enthusiastic persons. Personality development and language command, all these things are developing in their own, and along with your beautiful smile which you have provided them, they are very much happy and doing good in their career. So what happens actually is, when we go for any kind of orthodontic treatment, we go for an evaluation for complete things. So periodontal evaluation is very much important. That's why I'm here, and Prasad sir has beautifully explained everything. I'm not sure what I'm going to explain it right now, but Prasad sir has explained it very well. So myself, Dr. Satish Gupta, I'm here to discuss the periodontal consideration and treatment approaches in ortho-perio relationship. So what I'm going to discuss is the periodontal therapy, what problems, what things encountered in the periodontal aspect, like alveolar bone discrepancies, soft tissue discrepancies. Prasad sir has already mentioned some, like infrabony defect, furcation, soft tissue discrepancies like papilla loss, gingival enlargement. All these things we have already discussed. We'll see in a bit brief again. Then I'm going to talk more about periodontally assisted osteogenic orthodontics, also called as Wilcodontics. So which shortens the treatment duration of ortho. So this is all I'm going to talk. Now, alveolar bone discrepancy. Now these alveolar, when we deal with adult orthodontics, many times these alveolar bone discrepancies. Now earlier, as I say that the most of the ortho patients were aging ranges from 13, 14 to early 24, 25. But now, because of the increased awareness of dental procedures, increased awareness of aesthetic procedures, now all kind of age, they are more keen to get orthodontic treatment. They are more keen to have a tooth aligned, and they go for an orthodontic treatment more often. Now, in this case, what all things which I'm talking about on this screen is in the issues of adult orthodontics. Now, crustal bone loss due to progressive periodontitis. The main case of adult orthodontics is a progressive periodontitis which we have. What we do, what we should not do, we'll discuss. Now, dense cortical bone, healed extraction socket. Many patients has earlier extraction sockets which has been healed and converted into the dense bone. So this dense bone is very difficult. Tooth movement is very difficult in this dense bone. Now, furcation involvement, which sir has already discussed, infrabony defect and angular bone loss. This is all common we can find in aggressive periodontitis. Now, localized ridge defect, many extraction, traumatic extraction makes ridge defect, making difficult for the ortho tooth movements. Now, all these things which we are going to have a look. Now, progressive periodontitis. Let's have a look on that. Bone loss leads to change in the center of resistance. Now, what happens in progressive periodontitis is the crestal bone loss, or you can say interdental bone loss, they go more and more apically. Bone loss happens because of periodontitis. Right now, I'm stating periodontitis, and not aggressive, not chronic, any kind of periodontitis, they leads to bone loss. Now, these bone loss changes the center of resistance. Now, more tipping moment will occur rather than bodily movement. Many desirable treatment outcome we cannot get in this condition when we don't treat them, or when we don't go for a controlled continuous low forces. Now, treating them first is very much important, because the diseased periodontium will never give you appropriate results. Diseased periodontium is your diseased sac. Whenever I say that the periodontium, I always say periodontium is a mother of tooth, mother of sac of the tooth. So what tooth is going to happen, the movement, the rotation, the changing of the position, tipping, body movement, it all happens into the socket. It all happens into the periodontium. So unless your periodontium is healthy, you are not going to play with the tooth position. The desirable results will not going to be obtained. So make your periodontium healthy, make your mother healthy, so that you will get a nice and a predictable result. Now, in adult periodontitis, chronic periodontitis will not have a much problem because it is very much treatable and it is very much arrested. When we talk about treatment of periodontitis, we don't expect the bone gain. We don't expect that the bone which has already been lost in past, it is regained and then go for orthodontic treatment. We don't expect that. Arresting periodontitis is more important, right? There are different school of thoughts when to start, where to start, whether to do it or not. Different kind of bone levels various researchers have stated. But what happens is when the tooth is in early periodontitis stage, like if a chronic periodontitis stage, if it is an early periodontitis stage, 20%, 30% attachment loss, it is very much appropriate for the orthodontic treatment. The only thing is you need to treat it. What you need to treat it is go for a scaling, root planing, go for a curettage. Make sure that your gums is not going to bleed. You don't have bleeding on probing. You don't have mobility. You might have some slight of mobility, but you still can go for and make when you have treated the existing periodontitis, make sure that you have given enough time to heal it well. So 3 to 6 months, as Prasad sir has already said, go for a periodontal therapy, wait for 3 to 6 months, and then start with a slow, continuous forces as per your skill. Now, aggressive periodontitis. This is something very dangerous situation we landed up in some time. Though the prevalence of aggressive periodontitis is less, but it is not that much less that you don't find it into your OPD. Let me share one experience of me. I have encountered a patient. I have called from a clinician that doctor, there is a flap surgery case for you, and please come and get it done. When I went there, I saw the braces are already bonded on the anterior teeth 3 to 3, and when I evaluated the teeth, all the anteriors are almost grade 3 mobile. So I was just thinking of the why you have.
दरवाजा खोल दो क्रिस्टो, मतलब
Hello?
कंपोजिट भी रख दो लेकिन
Hello?
आरसीटी का भी लगा के रखो. धन्यवाद.
Hello? 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 Hello?
Yes,
Am I,
Satish, please
Yes,
carry
am I
on.
audible?
you can continue. बीच में, you can
Okay,
continue. You're audible.
Okay, fine. Okay, fine. So I'm talking about aggressive periodontitis. That lady, that girl was a 19-year-old girl, and completely grade 3 mobile from 3 to 3, upper maxillary anteriors from canine to canine, and I saw a braces on the tooth, and I asked the doctor कि sir ये इतना ऐसा क्यों हो गया? तो बोले the father of the patient said that we came here for the alignment of the teeth, and orthodontist started the braces, but since the case was aggressive periodontitis, it reacted exaggerately, and the tooth become mobile. The tooth become aggressively mobile within 2 months. So I was not getting what to tell the patient that you need to, and she was getting married in next month. She was getting married in a month. So I'm not in a position to tell the patient that you need to get it extracted right now, or you cannot do all this. You cannot do anything with these cases. And clinician wants me to do for flap surgery. So it happens many times, especially in rural area. So evaluating pre-procedural thorough periodontal tissue evaluation is very much important. Bother to take a periodontal probe, preferably with marking, probe it into the sulcus. You'll come. Don't go on the color and consistency of gingiva, because many times which appears pink is not always healthy. So even if you see clinically that gingiva to it's good and pink and healthy, so don't go on the appearances. Bother to pick a probe and probe it. And if you find 5 mm, 6 mm, 7 mm pocket around interproximal areas, go for OPG, go for LATSF. You always go for, but evaluate it very well. And even if you find that there is a slight periodontitis or a mild periodontitis, go for a basic non-surgical treatment for that. Don't go for don't rush to bond it and start the orthodontic retraction. So what I advise is we always go for a scaling for ortho cases, but you can go for a scaling, root planing, curettage, subgingival irrigation, what all kind of non-surgical therapy we have, you can go for it. And maybe after 3 months or maybe after 6 weeks, even a mild cases, you can start your orthodontic therapy with mild forces as per your skill. Surgical therapy is also conducted if you find the bone loss is not more than 50%, but pockets are deep. So in that case, you get it performed flap surgery for that case. Make sure that the disease is arrested well. Now, how you are going to come to know that disease is arrested and this is the time I should go for my braces? Now, for the periodontium, when the patient comes to you, patient may come to you for a bleeding gums, patient may come to you for halitosis, gingival enlargement, grade 2, grade 3 stains, calculus, all these things. But when you have treated periodontitis well and you show that the disease is arrested, at that time, patient should not have bleeding gums. There should not be a bleeding on probing. There should not be a mobility, progressive mobility. Maybe earlier the tooth was more mobile, now the tooth was less mobile. So you can be sure that this tooth was less mobile now. Make sure that the patient is maintaining oral hygiene very well. This is very much important, because if patient is not maintaining very well, he or she might be getting periodontitis again after placing your braces. So make sure that he or she is maintaining oral hygiene very well. So at that time, you're sure you can start your orthotherapy. Now, this is how we can control the periodontitis, chronic or aggressive. Aggressive periodontitis, I must say that you have to wait and watch for a long, because the tooth will landed up in any kind of case, in any scenario. So getting a tooth alignment, saving the tooth first is more important than getting the tooth alignment at that time. So aggressive periodontitis cases, I must say that. But for chronic periodontitis cases, you have to go for a therapy, arrest the disease, and very well you can perform your orthodontic therapy. Dense cortical bone, as I already said, that this happens if the patient is having trauma from occlusion, or patient is having excessive adaptive occlusal forces, is what? Hard biting, gutka chewing, supari chewing patient. It can cause buttressing bone formation for the buccal and palatal side. It can form a dense cortical bone on buccal, palatal, or lingual sides. So in this case, an old healed socket, as I said, it becomes so mineralized and hard that the tooth movements become so difficult at that time. Now, meaning what could we do for this thing is like resective osseous surgery we can think of, bone trimming we can think of. And eliminating trauma or excessive load on the teeth is very important, because the small and chronic trauma from occlusion will definitely lead to buttressing bone formation. So what you need to do is evaluate the occlusion, eliminate the high points, eliminate the premature contacts, go for a coronoplasty, make sure that the patient biting is very much the IMP, that is maximum intercuspation is possible, and cessation of habit is also important. If the patient is gutka chewer, pan chewer, it is also going to affect your braces in future. So cessation of habit is always good. This is how we can manage dense cortical bone. Furcation involvement, sir has beautifully explained it. Class 1, class 2, class 3, I must say grade 1, grade 2, grade 3, grade 4. Grade 3, grade 4, I won't say that it is good candidate for the ortho treatment, but yes, grade 1, grade 2, it can definitely go for ortho after treatment. See, periodontal furcation defects are very much prone to get regeneration. So regenerative therapy is very good and predictable in furcation defects. So if you want to treat it first, go for a regenerative therapy, go for a scaling root planing curettage, and then go for a GTR or just grafting, membrane, guided tissue regeneration. What kind of regeneration your periodontist will perform, that up to his skill. But after this regenerative therapy, maybe after 3 to 4 months, you can very well take that tooth as an anchorage. You can take that tooth for a orthodontic therapy. Now, for these things, we can also include extrude, alignment, uprighting. All these things can be done by orthodontist, and it will help and aid in the periodontal therapy also. Infrabony defect, again, sir has mentioned, angular bone loss. These infrabony defect, angular bone loss, these things are more common in aggressive periodontitis patient. Yeah, once you get a OPG, you'll very much find a mixed type of bone loss in that region. If the patient is not of aggressive, it might be because of food lodgement, might be because of faulty prosthesis, might be because of any high point or any trauma on the prosthesis, because trauma from occlusion of the molars, they directly hit to the furcation area. You'll see the bone loss at the furcation area at that time. So that trauma should be released. The periodontal therapy, of course, non-surgical therapy, surgical therapy. Now, intrabony defect can also be treated only by curettage. If it is a 3-wall defect, only curettage will also give you a gain in attachment. But for the regenerative therapy, again, you need to have a biomaterials, you need to have grafts, you need to have. Nowadays, I'm very much into the PRP, PRF. So I do every case now and then. I'm doing PRF, PRP for the cases. So GTR membrane. So all these things can be very much done for the regenerative purpose of this infrabony defect. Again, orthodontic treatment, intrusion, alignment, uprighting, all these things can be done And it can, like pathologic migration, like Prasad sir has also mentioned, various pathologic migration of the tooth will give you the infrabony defect region. But when uprighting of the tooth, tilting of the tooth, making the tooth align into the arch, they will not only eliminate the infrabony defect, it also give you the release of trauma, the good occlusion, and avoid the inadequate forces which is acting on that tooth. So here comes here we can eliminate angular bone loss only by orthodontic treatment also sometimes. Now soft tissue discrepancies, aesthetic aspect. Now as common aesthetic aspect which we see in ortho-perio relationship is a high frenum attachment, uneven gingival margin, gingival enlargement, missing papilla, black triangle, and gingival resection. All these things can happen during, after, or pre-orthodontic treatment. High frenum attachment we have already see that various classes of frenum are there. Now, and to be more precise, we get it mucosal attachment, attachment on attached gingiva, attachment on interdental papilla, and papilla crossing. So what grade 3, grade 4 we call as papilla crossing, where the frenum crosses the interdental papilla and attaches to the palatal aspect of the incisive canal area. Now, various school of thoughts, when to remove frenum, early remove, late remove. Many times, both the times we need to remove. The frenum is so thick that earlier also we need to, before orthodontic treatment, we need to remove the frenum, and after orthodontic treatment also we need some frenotomy at that time also. Procedure, many procedures. We need to go for scalpel, Z-plasty. We can go for a frenotomy by electrosurgery. We cannot go for frenectomy by laser or electrosurgery. You need to have a scalpel update when you have a complete frenum removal. I suggest go for a complete frenum removal even for the grade 1, grade 2, because you never know that which kind of fibers will reoccur after some time. And after this midline closure, after this midline diastema closure, there is a high chances of recurrence. So you don't want the fibers will come. What in contrary to that, what we want is there should be a scarring there. There should be a scar development there, so that the tissue and the fibers become so fibrous that it will not let the diastema open again. So the relapse of the treatment is again less. This is how the frenum attachments work. Now, uneven gingival margin, post orthodontic, pre orthodontic, even during the orthodontic treatment, the braces they hampers in oral hygiene. It's not new, and it is oral hygiene always led to the gingival inflammation. Now, this gingival inflammation, if it is not controlled at that time, it will definitely convert to periodontitis. Right now, it may be only limited to gingiva, but if it let go untreated, it will definitely convert to a periodontitis. So unless and until patient is very much cautious about the brushing, the hygiene, don't go for the ortho treatment. And if the ortho treatment you have started, make them realize every time that if you don't brush, you need to have a other surgical procedure need to be done. Many orthodontic treatment landed up in gummy smile appearance after some time. I have seen many Bimax cases which mostly after the treatment the patient shows gummy smile. So in that case, we can go for a aesthetic crown lengthening. We can go for a lip repositioning procedure, a beautiful procedure, a simple and a very minor surgical procedure. Many patients shows upper lip shortening. So even after completion of orthodontic treatment, lip repositioning needed for such patient. So gummy smile treatment comes to your aesthetic crown lengthening, which is nothing but a gingivectomy along with your 1 to 2 millimeter of crustal bone removal, that is osteotomy. And lip repositioning is nothing but a shortening of lip, shortening of your vestibule from the mucogingival junction to the lip. So it will give you a good and aesthetic results at that time. Missing papilla, sir has already told. Now, progressive periodontitis will always have a missing papilla. You cannot treat it. Treatment of papilla is very difficult. Now, orthodontically, what we can do, what you people can do is a repositioning of tooth to maintain the contact. Now, Turnow and Fletcher has given a principle. It has given a rule. What the rule is, when there is a distance of 5 millimeter from the contact point to the crest of the bone. So when you can see here, can you see my cursor? When you see here the contact point, this is the contact point, and this is where somewhere we have a crest of the bone. So if there is this is the crest of the bone and this is the contact point, this much distance should be 5 millimeter. If it is more than 5 millimeter, the papilla is going to lose, and if it is less than 5 millimeter, the papilla is going to grow more. There will be a more gingival enlargement in this region. So gaining papilla is different kind of procedure, different kind of procedure we can do. but the basic principle is 5 millimeter distance from the crest to the contact point. If you have it 5 millimeter, do the procedure will be predictable, and the graft will not reject, and the results will be for a long term. And if the this crestal distance and the contact point distance is more than 5 mm, it is very difficult to gain the papilla, and it is not for long term also. Again, papilla reconstruction procedure, orthodontically, you can reposition the tooth, re-rotate the tooth to gain a papilla on that place. Periodontally, we can gain a papilla by just simple curettage, activating the fibroblast in that area, will grow the papilla after some time. FGG, SCTG, FGG is nothing but free gingival graft, subepithelial connective tissue graft. All these are the periodontal plastic surgical procedures. The graft is harvested from the palate and placed it into the interdental area after preparing the recipient sites. Titanium pin reinforced papilla regeneration. This is something very advanced, in which where the 5 mm distance is also not there, still we can go for a titanium pin reinforced, but it is still in the process. So aesthetically, what we do is this closure of black triangle by this procedure is very much predictable. But yes, the tooth should be in very much aligned, and it should not be in a trauma. Otherwise, the results will recur. The black triangle will come again. Gingival recession. Now, there are many periodontal procedures which we can go for a coverage of the tooth. Orthodontically, just like this canine, it has a recession because of malalignment. You can get it aligned and you can get it corrected. The recession is itself get corrected if you get it aligned. And periodontically, what we do, we go for a CPF, FGG. CPF is nothing but a coronally positioned flap. So unless you have completed, if you're sure that there is a buccal bone, and if you show there is a gingival recession, there will be a predictable result for that. Miller has given the classification of class 1, class 2, class 3, class 4 gingival recession, in which he has stated that class 3 and class 4 has an attachment loss, has a bone loss, difficult to cover. Class 1 and class 2, they don't have bone loss, they don't have attachment loss. So class 1 and class 2 recession can very well be cured by these procedures like coronally positioned flap, pre-gingival graft, subepithelial connective tissue graft. All these procedures are very much predictable in case of coverage of tooth, coverage of crown, coverage of root in class 1 and class 2 Miller's gingival recession. Now, periodontically assisted osteogenic orthodontic, that is also called as Wilcodontics. Sir has briefed the amount. I will just repeat it again. PAOO, it is a clinical procedure that combines selective alveolar corticectomy, particulate bone grafting, and application of orthodontic forces. Now, as I said earlier also, that nowadays adult orthodontics is becoming more and more popular. More and more population, even in a later stage of the life, they want their tooth to be aligned. They want their tooth to be look good, aesthetic, smile design, all these things. They opt at the later age also. In that case, where the cortical plates are thick, where the bone has already been mineralized a lot, and the tooth movements become so difficult at that time. In this case, the history of Wilcodontics is not new. It's back to 100 years back. The man has already stated the concept of corticotomies, but it has not been developed then. So then Brian first described it, then Dr. Coyle, 1959, they have introduced the osteotomy techniques. They have given the osteotomy, vertical osteotomy techniques, horizontal osteotomy techniques for the acceleration of the orthodontic tooth movement. Then Wilco brothers have very much, they did a lot of work on that. They did a lot of research on that. They have come across a very modifications of this, and they have patented these things called Wilcodontics, and they have included various methods in that. So periodontally assisted osteogenic orthodontics or Wilcotomy, it is developed and flourished by Wilco brothers. Now, what is it? Researchers states that corticotomy facilitates orthodontics. They may say that there may be a 50% reduction in your treatment duration. You can fasten your treatment by 50%. If you can finish a case by 12 months or 15 months with Wilcodontics, you can finish it by 6 months, 8 months. But it is a bit invasive procedure, surgical procedure involved. I'm coming to that, to surgical procedure also. Because of that, it is less popular at that time also. This is how it comes. Corticotomies look like. Now, after giving a clavicular incision to all the teeth, most of the time we go for a corticotomies and maxillary and mandibular anteriors. What the motive is to to decorticate the area to reduce the resistance of cortical bone. Now, once you have given a full incision to the clavicular area, you have to raise the full thickness flap. You have to raise the full thickness flap beyond mucogingival junction so that you can get the horizontal cuts at the apex also. So this is how the corticotomies, the vertical corticotomies can be done. Narrow perforation can be done, and the horizontal corticotomies, it's not visible here, but in horizontal corticotomies it also been performed. So what Dr. Coyle has given the concept of block concept. Block, what he said is every tooth is separated by a block and joined by a medullary bone. What he stated that vertical and horizontal corticotomies will give you a block-like effect, one tooth, one block effect, and the tooth will migrate into the medullary bone only, and the corticotomies will heal naturally after that. This is how it looks. The reflection of the flap, corticotomies. You can place a bone graft, you can place a biomaterial on that, and you can suture it. Now, mechanism of action. Now, obviously, decrease resistance of a dense cortical bone. Now, as an adult orthodontics, as I have stated, that there will be a dense cortical bone due to various reasons. Now, these decortication will lead to the less mineralization of cortical bone, less resistance offered by the cortical bone, thereby enhancing the tooth movement. When the tooth is going to move, it experiences less resistance by cortical bone when you do this procedure. Enhance bone remodeling. By cutting the corticotomies, by giving insult to your bone, there will be an inflammatory response. Whenever you insult any tissue to the bone, there will be an inflammatory response. Now, these inflammatory response can be of various types. Now, various inflammatory cells, various receptors, various agents, various cytokines, rankle. These things are nothing but inflammatory mediators, which causes the bone remodeling in a very faster manner. Now, what rankle do is it started eating the bone. Now, what it do is it started osteoclastic activity. Just like in our implantology, we say that there is an osteoclastic phase when we place an implant. There is an osteoclastic phase after a week, and there will be a apposition phase after 45 days. Now, this 2 to 3 weeks period, it is
3 months. Right one mouthwash. Excellent mouthwash.
Hello.
You are muted, Satish. You need to unmute.
Hello.
Yes, you are audible, Satish.
Thank you, ma'am. So where we are in an inflammatory response. What we are getting an advantage of inflammatory response in Wilcodontics is when we give a vertical cuts, horizontal cuts, any insult to the bone, it is going to have an inflammatory response there. This inflammatory response make the bone softer for a few weeks. Like from the first week to 6th week, the bone is very much soft. It becomes a soft mud. So when you apply the orthodontic forces and try to move your tooth into that bone, when you go for an forces on that tooth, it will not go for a pulp devitalization. It will not go for a root resorption at that time. It will freely move into the bone, and it will give you a desirable result. After 6 weeks, the healing is okay. The corticotomies are going to heal very well. There will not be a much destruction of periodontal. Yes, of course, there are some, but not much destruction of this. These events is sometimes some people are called as regional acceleratory phenomenon, that is RAP. Now, these regional acceleratory phenomena, as the name suggests, it is nothing but a healing event. It is nothing but a healing mechanism, as I already said, just like extraction healing socket, just like any kind of surgical healing socket. What it goes is it enhances the bone remodeling. The inflammatory mediators enhances the bone osteoclastic cells, and thereby activating osteoblastic cells. And in this event, when you apply forces on a tooth, the tooth movement occurs very easily. So this is a reason why we get a faster results in Velcodontics. So that is how it works. Now, indications and clinical application. Resolving resolve crowding and shortening time period, obviously accelerate canine retraction after premolar extraction. And this velcodontics is not for all the cases. You are the diagnosing factor for that, which case will go for a velcodontics or not. The enhanced post orthodontic stability. One more thing, that the elasticity of bone mineralizes very well after the treatment, so relapse is very well. When you do corticotomies and get the teeth aligned at the time, the relapse of the treatment is very less in this procedure. In the conventional procedure, the elastic fibers, the elastic things, the elastic tissue into the bone, they are very much active. But in this procedure, they are fibrous, they are very much healed, they are very much mineralized when they crosses 6 weeks. So at that time, you will be getting all the kind of alignment done. So there will be a less chances of relapse. So it obviously facilitates the enhances the post orthodontic stability. It facilitates slow orthodontic expansion also, helps in molar intrusion and open bite correction, aid in the manipulation of anchorage. So all these things, these are the clinical applications which we have got. Now contraindication and limitations. Now obviously weak periodontium or active periodontitis case is a contraindication for these things. Active periodontitis case is a contraindication for any kind of orthodontic treatment. Gingival recession are not good case, because gingival recession are already given attachment loss on the buccal surface. So where you going to give a corticotomy cuts? So this is not desirable to give corticotomy cuts aside the tooth which is having a gingival recession. So this is also, these candidates are not good for that. And should not be considered as an alternative surgical assisted palatal expansion treatment, because the palatal expansion, surgical palatal expansion, where we split the papilla and places the various appliances in between that, this cannot be the replacement of that. And also should not be used in Bimax protrusion accompanied with gummy smile, which might benefit from more segmental osteotomies. Skeletal malocclusion, we cannot enhance the tooth movement in the skeletal malocclusion part. There we have segmental osteotomy will help us for that. Complication and side effect. Now these velcodontics, it may have an adverse effect on periodontium. Obviously you are insulting the periodontal area, you are insulting the cortical bone. So when if the cuts are not controlled, if the cuts are not healed properly after that, you may lose periodontium, you may lose crestal bone loss, you may lose interdental papilla. So these things can be done, can happen after the corticotomies after that. So periodontium can be lost. The problems may not happen. The problems may happen in the various form of loss of attachment, loss of papilla, gingival recession. Sometimes the all kind of complication of surgery can be happen there. Subcutaneous hematoma can happen. So this is what the side effects are. Now piezo-Sion. After this velcodontics had been successfully implicated the concept, piezo-Sion is nothing but a corticotomies by piezotome, the corticotome by piezoelectric surgical motor. So what they do is they try to reduce the trauma to the periodontium. At the same time, they are trying to achieve the osteotomy cuts. They are trying to achieve the excessive inflammation, but they don't want to raise the flap. So if you don't want to, if you don't raise the flap, if you don't raise the mucoperiosteal flap, there will be less insult to the periodontium. There will be less complication related to periodontal loss. So piezo-Sion is again one of the good and conservative approach of velcodontics. Piezo-Sion allows rapid tooth movement without downside of the extensive and traumatic classical surgical approach. As I said, you don't need to reflect the flap. It is easy to do. The corticotomy is performed without reflection full thickness, but you need a piezo-surgical unit. This is how we go. This is a micro incisions just into the interdental papilla. Now, between the two teeth, make mucogingival junction as your point and make a micro incisions. You need not to reflect the flap. You just need to incise in that area where you need to give the cuts. This is how you need to give the cuts by piezotome. This piezoelectric motors, you can run it vertically, you can run it horizontal also, but vertical osteotomy will be enough in this case. Now, if you want to place a graft, you need to raise a flap, which is something called an envelope flap. You don't need to raise a complete full thickness flap. Now, if you want to correct penetration dehiscence underlying the bone, so you need to place a graft there. So in the same procedure, you given a micro incisions, you have cut the corticotomies with piezotome, place a graft over there and suture it. Here you need suture it. Here you need to suture it because you have placed a biomaterial. You don't want that biomaterial to get infected, so you need suture. In this case, we don't need suture. In this case, we just need cut and the osteotomy. Sorry, incision and the osteotomy. That's it. You don't need suture here. That is why this is more conservative. It's predictable and conservative, and you'll get that advantage seen. Now, obviously, less invasive. It has less surgical invasive procedure, no sutures, nothing. Less post-operative discomfort, less periodontal tissue destruction. All the disadvantages which we have seen in the conventional vilcodontic procedure, they can cover it here. Disadvantage, of course, it requires a special instrument called piezoelectric surgery. Blind procedure. It is a blind procedure because we don't raise a flap. We don't see where we are going to cut. We don't see the root. We don't see the vital structures. So maybe because of this a blind procedure, we may damage the root surface. We may damage the root tip. Many times nerve, mental foramina, all these things are there. When we raise the flap, we can see these things and we can avoid these things. But this Physiosion procedure, there is we don't raise a flap, so there is a blind procedure. So in this case, the disadvantages belongs to this blind procedure only. Now coming to the conclusion, an interdisciplinary approach leads to an optimal qualitative, functional, and aesthetic management, providing the best treatment plan in the complex scenario. It may belong to a parental origin, it may belong to an orthodontic origin, but or it may belong to a synergy of both. But when we go hand in hand, when we go simultaneously the treatment plan with respecting each other, we can deliver an awesome desirable results to the patient, and we can give it to. Thank you. Questions welcomes.
Any questions? Please put it in the chat box. We'll deal with them at the end of all the lectures. So is it okay, Satish?
Yes, definitely.
That was a very wonderful presentation. You managed to keep it in time. That was perfect.
Thank you, sir. Prasad sir makes my job very easy.
Thank you, sir, for the informative insight into the perio-ortho relationship. As a token of appreciation, we'd like to present sir with the certificate. Kindly accept it, sir.
Thank you. Thanks a lot.
Once again, we'd like to welcome Dr. Prasad Konda, sir, for the lecture on orthodontic consideration in orthosurgical relationship. Over to you, sir.
Thank you. Yeah, will you be able to see my slides?
No, sir, not yet.
Not yet.
Now?
No, not yet.
Hello?
Yes,
No,
sir.
no. The slides are not visible.
Slides are visible, right?
No, sir, the slides are not visible.
Just a second.
They are not visible.
Now?
Yes, sir, they are visible now.
The slides are visible now.
Yeah, thank you. Thank you, Satish, for enlightening me also for various periodontal procedures. Along with the students, I'm also learning new things. Thank you, Satish.
Sir, I wish you can make my job also easy.
No, Abhilasha, you are doing more of surgical things. I'm just giving introduction to the surgery, not much into the surgery levels. Okay.
Thank you, sir. Thanks a lot.
Yeah. So now we come across like orthodontic considerations in ortho-surgical relationship. In the earlier lecture, we have seen what an orthodontist should consider in case of your periodontally related structures of a tooth movement, whether it is a healthy or a periodontally involved tooth. Whereas in case of your orthodontic surgical relationship, I have an utmost respect, which I developed for the maxillofacial surgeons, that too after attending a couple of my orthognathic cases in the operation theater. It's not just easy, I can say. So now we'll see what are the orthodontic considerations in ortho-surgical relationship. So to begin with, I have a little bit of questions for everyone. So these questions will be answered later Who exactly needs some surgical orthodontics? Why is surgical orthodontics necessary? What causes the need for the surgery? Which come first, surgery or the orthodontic treatment? So in many cases, we have in the present scenario, we have come across like surgery first. What exactly is the surgery first? In such cases, whether a surgical orthodontics is required or not, we'll see later. Is surgical orthodontics only necessary for the jaws that are misaligned, or is it required for someone else also where the jaws are not misaligned by the nature itself? Is surgical orthodontics performed only in adults? Is orthodontic treatment always required in surgical orthodontics? If there is any jaw discrepancy, only the surgical part will not suffice. Whether they require any orthodontic treatment before or after, in such cases we'll see. Can surgery by itself align the teeth and jaws? Is the surgery performed by the orthodontist or by an oral surgeon? So as Satish said, nowadays we are coming across more of adult cases where they are interested for their aesthetics. They are much worried about their function. So for some adults, orthodontic treatment alone cannot correct their complete problem. So only the orthodontic treatment will not have a complete problem. In such cases, we may need, when the jaw discrepancy is there, when the skeletal discrepancy is there, in such cases, we need a surgery as well as an orthodontic treatment to achieve functional and healthy bite. Surgical orthodontics is also called as orthognathic surgery, which is nothing but a corrective jaw surgery, which is performed to correct the skeletal discrepancies which are there for the upper jaw and the lower jaw. The surgeries may be performed either in the upper jaw or in the lower jaw or a combination of both. So orthodontic treatment is done before the surgery and as well as after the surgery, so that upper and lower teeth meet appropriately and individuals are able to bite, chew, and speak. So the function has to be improved. That is for that reason, and aesthetic has to be improved for that reason. Orthodontics as well as surgical part has to be carried out. So if you see across like Jackson's triad, so what is the Jackson's triad? We need to develop a structural balance amongst the structures of either bony structure or soft tissue structures as well as dental structures. Functional efficiency has to be improved. It may be a temporomandibular joint function or occlusal function, as well as aesthetic harmony has to be developed. So orthodontic treatment can be divided into 5 categories. As I said, aesthetics, maybe a facial aesthetics or a dental aesthetics, functional occlusion, periodontal health, and stability. This we need to keep in mind all these parameters when you are doing any orthodontic case. But when you're thinking about a severe skeletal deformity, which is existing in a non-growing patient means nothing but a patient has ceased his growth, which can be assessed. That is nothing but a skeletal growth, which can be assessed with the help of your cervical vertebra maturation index or hand wrist radiograph. When the patient is ceased with that growth, when you have a severe skeletal deformity, the orthodontic treatment goals alone will not be achieved just by orthodontics. Our treatment goals will not be just achieved by orthodontics. We need to have a surgical as well as orthodontics together play an important role in such cases. So in these circumstances, as I said, orthodontics and surgery is required for the correction of your dental malposition as well as your skeletal disharmony. This corrective jaw surgery, also called as orthognathic surgery, is performed by oral and maxillofacial surgeons to correct a wide range of minor as well as major skeletal irregularities. Minor skeletal irregularities, as I can say, a genioplasty or change in the position augmentation or something like that can be considered as minor surgeries, whereas your Lefort surgeries or bijaw surgeries can be considered as a major surgeries for the improvement of your biting habits of the patient, speaking as well as breathing of the patient. So how do you say that breathing of the patient is improved? So when you have a skeletal class 2 maloclusion with the help of your retruded mandible, we know that airway space will be reduced in such cases. In such cases where you want to plan for the advancement of the mandible, the breathing of the patient definitely will improve. It generally takes about 18 to 24 months pre-surgical as well as surgery and post-surgical cases. So we need to do a case pre-surgically to align the teeth, restore the decompensation and all. We'll see one by one later during the presentation. So A treatment may be divided into 4 stages. One is your treatment planning, pre-surgical orthodontics, surgical treatment, and post-surgical orthodontics. So out of these 4 stages, most important stage is your treatment planning. You're convincing the patients for the surgery and plan the case for the surgery. The patient is convinced for the surgery and you are starting with an orthodontics. You can't step it back. If you are planning exclusive only for the orthodontics, your planning will be different. If you're planning exclusive for the surgery as well as orthodontics, your planning will be different. So treatment planning is a most important step. How exactly you want to perform. This planning has to be done in coordination with your maxillofacial surgeons. So treatment and planning, as Ackerman and Profit has given the concept of envelope of discrepancy, we all know that orthodontics alone will do a minimal tooth movement within the range which is shown here in white. Orthodontics and orthopedics may be a greater area of change can be achieved with the help when the patient is growing. Advancement, maybe a vertical movement or opening or bite closure can be achieved much higher than orthodontics alone. So in the patient is growing. With the help of your skeletal anchorage, where you have an absolute anchorage techniques where you don't want to lose the anchor to move forward. In such cases, further tooth movement can occur. For example, if you're retracting an incisor, retracting an anterior teeth, in case you are taking a support of your molars, invariably there's a chances of mesial movement of your molars or the posterior segment into the extraction space. So in order to retain that complete extraction space, approximately you will get 7 millimeters and 7 millimeters with the help of your extraction of your 4-4. You want to utilize that complete space for the retraction of your anteriors. In such cases, you need to take an absolute anchorage or the skeletal anchorage with the help of your tats, so that the retraction mechanics is completely utilized for the mechanics can be completely utilized for the palatal movement or distal movement of your anterior segment. If you want a still larger amount of jaw movement or correction is required, then the only option is your surgical planning, that too after completion of your growth of the patient. So what are the basic things that just any postgraduate or any orthodontist to do? Is first thing is your clinical evaluation, whether the patient is a surgical. You need to develop your talent by just seeing the patient clinically, whether this is the case is a borderline case where you can camouflage, or whether the case is just an orthodontics case where the case is goes for the surgery. So when the patient is absolutely for the surgery, you try to convince for the patient for the surgery. So when the patient is ready for the surgical aspect, you need to do a clinical evaluation, complete clinical evaluation of your soft tissue, hard tissue examination and all. You need to take a conventional radiographs like lateral cephalogram. If the patient is asymmetric, you might require sometimes an anteroposterior radiograph also. So coming to the cephalometric analysis, Burston has given a soft tissue analysis as well as your hard tissue analysis. So in this, with the help of an acetate paper which is overlapped onto the lateral cephalogram, you mark different landmarks onto the paper and different planes are being marked. In this case of your Burston analysis, you develop a true horizontal plane, which is 7 degrees from your SN from N towards upward direction. Many of them, they answer, you draw an horizontal plane from SN from N. It's an incomplete answer, whether you are drawing it downwards or upwards. That is you are supposed to measure. From there, you draw a perpendicular, which is called as true vertical. All these parameters, all these readings are projected onto the true horizontal or true vertical. Why this is important in case of your Cox analysis or a Burston analysis compared to other analysis is nothing but this is a surgical case. Linear movement of your either maxilla or the mandible is very important during the time of surgery, which as an orthodontist, you're supposed to guide your maxillofacial surgeon. How many millimeters of your retraction, how many millimeters of your protraction has to be done. As I said, we have one example I have given is the Grumman's analysis for in case of your anteroposterior discrepancy, where you have an asymmetry, where you have asymmetry in the temporomandibular jaw region, where you have asymmetry in the angle of the mandible, or your complete face, mid-face chin point has been shifted left or right. You have one more analysis called as Ricketts analysis. So cephalometric analysis is important. Hello. Yeah. Along with the cephalometric analysis, your photographic analysis will play a key role in case of your surgical orthodontics as well as your regular orthodontics. You need to evaluate your vertical half of the face. You need to design, you need to trace, just as you're doing in the cephalometrics or cephalogram, you're supposed to trace the photograph in this fashion. Your inner canthal line should be equal to the width of the nose. A pupillary line should be in line with your corners of the lip, whereas your outer canthal line should fall at the chin level. So all these things, vertical halves as well as horizontal lines, are very much important in case of your photographic analysis. So this is a conventional method where you do photographic analysis, your cephalometric analysis, even during your post-graduation, all the colleges nowadays. We have a latest technologies called as softwares also will be available. We just see in the coming slides. So we need to think about who will get benefited with this. Whether the treatment will be definitely benefited. For example, if you have a jaw discrepancy of 2 to 3 millimeters, the soft tissue envelope will mask it. Whether for the discrepancy of your skeletal discrepancy of your 3 millimeters or 4 millimeters, do we need to plan an orthodontic surgery? We need to think about that. Jaws that are positioned incorrectly. So when the jaws are definitely positioned incorrectly, we need to plan for an orthodontic surgery. Patients who have not had a benefit of dentofacial orthopedics due to lack of awareness, even today, in many cases we come across with lack of awareness of your dentofacial orthopedics, they will not get their child to an orthodontist at the time of your growing. So when we detect such discrepancy of your upper and lower jaw, predicting the growth of your both the jaws, how it will probably do at the time of your growth. Accordingly, we can plan dentofacial orthopedics, which simplifies that mechanics as well. So when the patient is having a no potential growth, so in such cases are eligible for your surgical cases. Once the treatment is started, it is hardly possible to reverse or suspend it. This is one point which is very much important. So I came across one case where they agreed for the surgery at the beginning of the treatment. I started pre-surgical orthodontics, but during the course of time, generally have a tendency that they keep contacting their friends, the relatives and all. So they say that the surgery is very like a risky process, why you are going for it, and all such things will happen. So in such cases, they will drop from idea from your surgery part. So what you're supposed to do in such cases is very difficult to reverse or suspend it. So entire treatment planning is gone. Entire your mechanics is, for example, if they're telling you in the span of 1 to 2 months, just in the aligning stage, that is a different issue. But if they're telling you maybe after 6 months or 8 months, then it's very difficult. So we need to have a joint treatment plan along with the maxillofacial surgeon. Thorough examination has to be done, a facial examination, dental photographs and facial photograph has to be done. Cephalometrics, your lateral cephalograms, as well as your anteroposterior, plus the dental models has to be checked whether the patient is, what you're supposed to check in the dental models. When you're doing a class 2 case, when you're trying to advance the mandible, well, that maxillary and mandibular dentition is in coordination with it or not. If it is falling into a crossbite, we need to think about expansion in the upper arch or the maxillary dentition. So, as I said, the dental facial skeleton and dentition as soft tissue plays a very important role in case of your triad. Facial soft tissues, facial skeleton and dentition. As I told you, we have a minimal discrepancy of a facial skeleton relationship, about maybe 3 to 4 millimeters. The soft tissue itself is masking it. So we need to think about these 3 aspects, the facial soft tissues, skeleton, as well as dentition. These are the most important factors which an orthodontic surgery cases has to be considered. As I said, these are the conventional methods, the cephalograms, tracing and all. We have something called as 3D technologies such as a multiplanar CT and MRI, 3D photography modalities and surface scanning. This will reduce the burden of your tracing, reduce the burden of your imagination, how the patient is going to look after surgery and all. So this is nothing but a software which I've developed. We can explain to the patient how the patient is going to look, how the patient is looking at the time of at the beginning of your treatment, and how improvement is going to take place in case of your upper jaw and the lower jaw with the help of your softwares. that can be feasible, and we can convince the patient very well. So this picture shows a dolphin image where you have an integrated of your skeletal structures, the maxilla bone and the mandible bone, overlapping onto the soft tissue. So if you change the maxilla forward, if you want to do the maxilla forward, how the nose tip and how the upper lip is changing. If you're retracting, for example, if you're moving the mandible back, how the chin position has been changed, how the lower lip relationship is changed. So these changes can be visible on the software. So ultimately, what is required is nothing but your image fusion. So though we have n number of techniques, you need to imagine three-dimensionally how the patient is going to look. That is an important of an orthodontist, to imagine a patient when they walks into your clinic, how the patient is going to look at the end of 2 years during with my orthodontics alone, with my orthodontics and surgery together. So that is important. So what are the things you're supposed to do in case of your pre-surgical orthodontics? It's nothing but orthodontic preparation for the surgery is different from the orthodontic correction itself. As I told you, we need to decide whether you're treating a case with the surgery or you're treating a case only orthodontics. Those two things are different. Your planning will be different. Your mechanics will be different. Achieving an optimal facial aesthetic requires integrated cooperation of your both the specialties, as I said. So routine preoperative procedures, what all we are supposed to do is dental alignment, incisor decompensation, arch coordination. These three things are very much important for the purpose of achieving a maximum intercuspal interdigitation when the jaws are surgically aligned. So we'll see one by one what is in the short, aims pre-surgical treatment to decompensate your lower and upper dentitions, level align the both arches. If you have a curve of SP, you need to level and to be limited arches and relieve the crowding. Crowding has to be relieved. In order to relieve the crowding, sometimes we may think about in the extraction pattern too. If the crowding is severe, where we can't align, we can't incline the teeth to the normal level, we need to think about an extraction pattern also. In general, these corrections will make the malocclusion look worse pre-surgically. Many patients complain about this. So my teeth were well aligned, I was looking much better, but after starting off my orthodontics, I'm looking more worse. You need to explain this step well beforehand to the patient. So to sum up, essential steps of your orthodontic preparation for orthodontic surgery is to align the arches individually, achieve compatibility of the arches or arch segment, establish a proper anterior-posterior relationship and articular position of the incisors. So what you're supposed to do in such cases, when you have a class 3 case, you have a dental compensation which has been occurred with help of a nature, that is anteriors will be proclined. Your upper incisors to NA is 22 degrees normal value, upper one to SN is 1 or 2 degrees. So this inclination will be exaggerated by the nature to compensate the skeletal discrepancy. So if you are planning for the surgery, what you are supposed to do is you are supposed to get the inclination at the normal level. Whereas in case of your lower arch, which is your jaw is much placed ahead, or your length of your ramus is length of the body of your mandible is much ahead, you will have a slight retroclination of your teeth, where your IMPA is supposed to be 90, it will be reduced or maybe to 80 or 85. You need to correct the inclination of the teeth before this surgery. So what dental alignment is needed? Dental crowding, spacing has to be closed, dental crowding has to be relieved, misalignment and rotation of the teeth should be corrected before any orthodontic surgery. As I told you, the key is to get the teeth in the proper position and angulation. You all know that what Steiner has given, what the Downs has been given, the position of your incisors as well as your upper and lower incisors, what Weed has given for the angle. All those normal values try to achieve. So when you're trying to achieve the normal inclination or normal angulation of your incisors, when you're decrowding the teeth, if the space is not sufficient, you might require an extractions. So extractions can also help to remove the dental compensation. It should be taken into consideration that extraction should be avoided. The space of the jaw permits the favorable dental alignment. If you have a sufficient space which can allow the teeth to align, then you don't need to have any extraction patterns to be carried out. So we come across a case like this. Is a severe class 3 case where you have a retruded maxilla and a prognathic mandible. So in order to align the upper arch, see this, how the canines are highly placed. The incisor inclination seems to be okay, but in order to accommodate this canine into the arch, you don't have a sufficient space. In such cases, as I do in case of your self-ligating brackets, this can be aligned very well without the extraction of your premolars. If your jaw surgery, which is planned for the prognathic, for the advancement of your maxilla and the retraction of retruding of your mandibular jaw, lower jaw, right? So in such cases, if that is not feasible, then we need to plan for the extraction of your premolars, get the canines into the alignment, and align the upper arch. Lower arch seems to be well aligned, but only thing is you have a curve of spee. Little amount of curve of spee can be corrected post-surgically, but if you have an exaggerated curve of spee, pre-surgically it has to be corrected. So decompensation, as I said, it's not only done in case of your anteroposterior direction. The compensation has to be done in case of your transverse as well as your vertical, both sagittal, transverse, and vertical. All three planes you are supposed to do the dental decompensation. So what are the factors which are responsible for the dentoalveolar adaptations? This is nothing but your normal eruptive system. Surrounding soft tissue pressure, the influence of neighboring and opposing teeth plays an important role for the dentoalveolar adaptation. For example, in case of your class 2 skeletal malocclusions, the upper teeth retrocline to compensate for the maxillary prognathism, and the lower teeth procline to compensate for the mandibular retrognathism. As I said, so you have in case of your class 2, so upper teeth are retroclined to compensate for the maxillary prognathism. So in such cases, what you're supposed to do is try to get the normal inclination of your teeth irrespective of your jaw relationships. Similarly, in case of your class 3, the upper teeth anteriors will procline to compensate the maxillary retrognathism. In such cases, you have this procline incisors. You upright them and make them get into your normal inclination. So lower incisors seems to be retroclined to compensate for the mandibular prognathism. You need to upright the lower incisors, get them into your 90 degrees of your IMPA values to compensate for the whatever the retroclination that is seen in case of your skeletal class 3. So pre-surgical decompensation is necessary to remove any dental compensation that are present. This will enable the surgeon to establish a clear idea how much a jaw movement has to be achieved. So if you're not doing this decompensation, you have a restricted movement of your jaws will be there, which a surgeon will not able to plan how much a jaw movement, either your forward movement or your backward movement of your jaw has to be planned, will not be possible for the surgeon to plan it. So failure to fully remove the anterior incisor compensation pre-surgically will limit the surgical correction, as I said earlier now. Such anteroposterior dental compensation may involve specific extractions, as I said. It requires an anchorage needs and use of a class 2 or a class 3 elastics. In case of your decompensation of your skeletal class 2 malocclusion, we often require use of a class 3 elastics. Class 3 elastics, nothing but your upper posterior segment to that lower anterior segment to upright the lower incisors, and to decompensation of your class 3 malocclusions, we require a lever's elastics, nothing but your class 2 elastics from the lower posterior segment to your upper anterior segment. During the compensation process, you are not supposed to forget the arch coordination. So arch coordination, as I said, just imagine a class 2 when you're taking a bite in case of your orthognathic or growth modification cases. When you're trying to ask the patient to advance the mandible, when they're in a proper occlusion in a class 2 fashion, when the patient is trying to get the mandible forward, there's a chances of developing a crossbite in the posterior segment that you are supposed to take into consideration. When your cases are such like that, then you are supposed to do an arch expansion. If the cases are in the reverse, you are supposed to do for the arch contraction. Occlusal plane leveling and alignment is must. So these arch coordinations along with the inclination of your teeth has to be taken care. So when you have a poor arch coordination, this will restrict or destabilize the jaw movements which a surgeon can do. So you need to have a proper arch coordination as well. along with your inclination of your teeth. As I said, pre-surgical orthodontics objectives in the transverse plane. What are the things which you are supposed to consider? Width of the maxilla should be slightly more than that of your mandible to produce a normal buccal overjet. So if you see the teeth, you have a buccal overjet. Always your maxillary dentition is slightly buccally placed compared to your mandibular dentition. Always keep in mind when you're advancing the mandible, just how the occlusion is going to end up in the buccal side. So if that is not there, you need to plan for the expansion of your arch in the upper jaw. The transverse discrepancy happens when there is a defect in the widths of the arches, as I said. So pre-surgical orthodontic treatment considerations in the transverse plane, the problem may be a skeletal or a dental. So if you have a dental discrepancy, then you are supposed to treat them by tipping those posterior segment from the premolar to molar just by buccal tipping. If it is a skeletal discrepancy, so that needs a bodily movement of your tooth, so which is possible maybe with the help of your segmental osteotomy techniques without the need of an orthodontic expansion alone. So in such cases, segmental osteotomy has to be done. So in case of your lingual tipping of your buccal teeth are there, a pre-surgical orthodontic expansion has to be considered. However, the tipping. Hello.
Yes, sir, you are audible.
Yeah. Not exceed 4 to 6 millimeters. If the tipping is exceeding more than that, it's really slightly unstable for the buccal occlusion. So if the problem is relative or absolute, we need to think about that the transverse discrepancy, whether the maxillary constriction is in relative or absolute. If it is an absolute discrepancy, then we need to plan, as I said, surgically assisted rapid palatal expansion has to be done for the correction of your transverse discrepancy in case of your maxillary arch. So pre-surgical orthodontic objectives in the vertical plane. How do you think when we come across your cases with your open bite as well as your deep bite, how to handle those cases pre-surgically when you have an open bite like this, a skeletal open bite? The treatment of anterior open bite has always been a great challenge, really a great challenge in case of your orthodontics. Extrusion of anterior teeth and orthognathic surgery are among the possible options for the treatment of open bite in non-growing patients. What you try to do is, in the pre-surgical manner, you try to extrude as much as possible, which is a mistake which generally I do, which land up in a gummy smile at the end of your surgery. However, as I said, dental extrusion of skeletal open bite will be unstable in long run. Furthermore, it creates an excessive display of your gums, which is not required or not has to be done. So whether you did this opening of your open bite has to be corrected. You're supposed to think how your open bite has to be corrected with the intrusion of your posteriors or slight extrusion of your anterior that has to be planned. Yeah, that depends on your curve of P. The severity of the curve of P indicates the need for your segmental osteotomy. We consider the curve of P should be minimal from 0 to 1.5 millimeters is considered to be normal. Beyond that, beyond the 1.5 millimeters, we are supposed to measure it at the premolar region. We need to align the teeth into the occlusal plane. So level the curve of P pre-surgically within the segments, within the limits of your this thing completely will not be done in case of your, especially in case of your open bite cases. So pre-surgical orthodontic considerations in open bite, avoiding closure of your anterior open bite pre-surgically by extruding the anterior teeth, avoiding closure of your anterior open bite pre-surgical by intruding the posterior teeth. Though these two things, you have some limitations, how much to be done and all. Again, a reverse curve of P should be leveled to some extent, but not completely. So this will give a limitations for the maxillofacial surgeon if you're doing it more exaggerated treatment during the pre-surgical manner. It will give a limitations to the surgeon to correct a skeletal open bite. So leveling the maxillary arch in the presence of a flat curve of P with no vertical discrepancy within the limits of the arch, leveling is done with a continuous arch wire. You don't require a special arch wires for the flat curve of P in case of an open bite. So this can be leveled and later it is corrected with the help of your Lefort one osteotomy. In case of your leveling the lower arch, mandibular arch. Since the patient is with an open bite, generally do not have a severe reverse curve of speed in case of your lower arch. So placing a continuous arch wire will definitely level the teeth as it is required for the, as it requires in case of your pre-surgical orthodontics for the surgeon to perform an open bite correction. In case of your deep bite, where you have an lower facial height is reduced, you will definitely have in such cases the deep bite maybe because of your infraocclusion of your posteriors or a supraocclusion of your lower anteriors. We have generally excessive curve of speed. We have generally excessive curve of speed. So in these cases, the curve of speed is leveled by intruding the incisors or excluding the posterior teeth. So how do you decide whether you want to do the incisors intrusion or extrusion of the posteriors? That depends ultimately on the initial facial height of the patient. If the patient facial height, lower facial height especially, is low, then the correction of curve of speed is preferable for by doing the extrusion of your posterior teeth, so that your lower facial height will match with your mid facial height as well as your upper facial height. So all this planning has to be done before evaluation and pre-surgical procedure. After alignment, after leveling, after correction of your inclinations of your upper and lower anteriors, we need to take impressions at the pre-surgical stage. You need to take the pre-surgical stage, mount them in the fashion you want. That is nothing but I'm talking about a mock surgery. Prepare a splint. This splint, for example, if you're doing a class 2 correction, you just get the mandible in advanced position in the class 1, how much advancement you are planning to do. If it is a bijaw, do the segmental osteotomies on the model, get the maxilla back, mount them in a class 1, prepare a splint like this. This splint plays an important role in case of your operation theaters for the surgeon to place upper and lower jaw, how much cut has to be placed, how to stabilize your maxilla, and how to stabilize your mandible. So this is a conventional method which you generally follow even in many colleges today. We have CAD/CAM technology that is involved in latest CAD/CAM technology that are involved for the preparation of your splint. If you have a jaw asymmetry is there, a left side cut, maybe for example, if you are doing a 2 millimeters, sometimes we have 4 millimeters cut on the right side for the correction of your asymmetry of the jaws. So such way we prepare the splint. So different orthognathic surgeries which are done in a variety of osteostomies will be elaborated by Abhilasha. So this is Lefort 1 maxillary osteotomy, Lefort 2 osteotomy, segmental sagittal split osteotomy, vertical ramus osteotomy. So these are all the different procedures which generally they take up, and we are also giving an information what type of surgery, what type of aesthetic information we are expecting into that patient. So in coordination with the surgery, we need to plan. So ultimately, surgery technique will be done by the maxillofacial surgeons, will be suggested by the maxillofacial surgeons. So what are the things which you are supposed to keep in mind and inform the patient after the surgery? We can expecting definitely a edema or the swelling of the patient. Nasal congestion will be there, and there will definitely an hospitalization for about a week, which have a difficulty in eating and chewing of food for maybe approximately 1 or 2 weeks following surgery. So all these instructions has to be given for the to the patients before the begin with the treatment. So what are the things we are supposed to do post-surgical orthodontics? Approximately after 4 to 6 weeks, nearly about 1.5 months after the surgery, you ask the patient to come back to you for the post-surgical treatment of your post-surgical orthodontics. This short phase of orthodontic treatment post-operatively is necessary to detail the final occlusion. If there is any intercuspation, definitely there will be an intercuspation discrepancies will be there. Final settlement of occlusion has to be done post-surgically. The goal is to settle the teeth in good occlusion, and alignment has to be done in case of your upper and lower arch. You need to have a cusp and embrasure relationship. So generally a post-surgical orthodontics may last for about 6 months. And then later on, we need to have both upper and lower retainers. What are the common mistakes generally an orthodontist will do in case of your pre-surgical orthodontics? The orthodontist should avoid masking the skeletal discrepancy by dental camouflage. If you are planning a surgery in any case, try to mask the skeletal discrepancy by dental camouflage. You're not supposed to do a camouflage type of treatment when you are planning for the surgery. If the patient is not willing, if the case is a borderline, definitely you are supposed to do the case with the help of your dental camouflage. But if you are planning for the skeletal discrepancy and with the help of an orthodontic surgery you are planning, dental camouflage should not be done in a pre-surgical orthodontics. Closing the anterior open bite pre-surgically by excluding the anterior teeth in open bite cases, this we already discussed. Closing the anterior open bite pre-surgically by intruding the posterior teeth in the open bite cases. Aligning the dental midlines in the transverse plane. If it is a skeletal discrepancy, if the midlines are not matching, don't try to align the midlines. Don't try to get the midlines match in case of your dentition, in case of your surgical cases. Correction of overjet in class 2 malocclusion cases. Don't try to correct the overjet. Try to maintain the inclination of your incisors to the normal norms. Don't try to correct the reverse overjet in case of your class 3 malocclusion. Let the case seem worsen, let the malocclusion, that the incisors seem worsen with the patients. That is the right way to do. Don't try to correct the overjet, or don't try to correct the reverse overjet in case of your class 3 or class 2 malocclusions. We have posed a few questions at the beginning of your presentation. Who actually needs a surgical orthodontics? A surgical orthodontics is necessary for the one who are having a discrepancy in the lower and upper skeletal, like maxilla and the mandibular jaw, and whose growth is completely stopped. It ceases with the help of your hand rest and CVMI. We have checked it. So your orthodontist will work in conjunction with an oral and maxillofacial surgeon to position the jaws for the optimal function. Why is a surgical orthodontics is necessary? Unlike children, what you do in case of your children, you do the growth modification. That growth modification is not possible in case of your adults, where your growth is ceased. In such cases, there is no other option other than your surgical orthodontics for the modification or the reposition of your upper and lower jaw. What causes for the need of the surgery? Root cause is nothing but your genetics. You're growing, your upper jaw and lower jaw is not in a proportion to each other. Then what is the option after season of your growth is nothing but is a surgery. So this is helpful for the improvement of your bite, the improvement of your speech, improvement of your breathing. What comes first, a surgery or orthodontic treatment? So 90% of the cases which requires an orthodontic surgery, so many cases require a pre-surgical orthodontics, unless until you don't have a crowded teeth. For example, the faces are well aligned, there's no crowding, no rotation, the teeth are very much inclined in the upper teeth are very much inclined in the upper jaw, where lower teeth are very much inclined in the lower jaw. In such cases, we can plan a surgery first, but it's very difficult to get a case without any crowding, without any rotation, without any change in the inclination. So most of the cases we require a pre-surgical orthodontics. Is surgical orthodontics necessary only for the jaws that are misaligned? So we may require the cases where you have a fracture of the jaws. Generally recommended for the adults who have a severe problem within the position of the teeth and the jaws, cannot be corrected by orthodontic alone. So in such cases we require. In the cases where their patients come across an injury with the help of an accident, or we have any birth defect, in such cases also we require orthodontic surgery. Is surgical orthodontics for adults? Definitely, yes. Who finished, who has completed the growth. You're always, for example, the patient is reporting to you in the growing phase, but you think that the patient can't be treated with the help of your growth modification, then it's better to wait and you reevaluate the case after we call the patient after completion of the growth, maybe after 18 or 20 years, then only you can perform a surgical orthodontics. Is orthodontic treatment always required with surgical orthodontics? As I told you, it's many of the cases, whether in the finishing, even if you're doing a surgery first also, later for the post-surgical orthodontics, we definitely requires orthodontic treatment. Can surgery by itself align the teeth and jaws? Definitely impossible. So they, if any patient thinks that only the surgery is needed, I don't want the braces treatment. So jaw correction may be achieved to some extent, but it's highly impossible to align, to get into a cusp and embryo relationship without the role of an orthodontist, without the role of a braces. Is the surgery performed by an orthodontist or a behavioral surgeon? Orthodontist can give a suggestion or give an idea what you are expecting, but ultimately it's done by your maxillofacial surgeon. To sum up, successful treatment of the patient who is a candidate for orthognathic surgery requires a close cooperation between both the specialists like orthodontist and a maxillofacial surgeon. Prior to surgery, the patient undergo orthodontic treatment in order to be prepared for the corrective jaw surgery. So the steps has to be vary from case to case based on the type of malocclusion and its severity. As I said, if the severity is too much, the pre-surgical orthodontics might take about 6 months to 12 months time for the pre-surgical orthodontics before this patient is ready for the surgery. So all these things has to be done in coordination, right from your first step to your last step. You should be in coordination with your maxillofacial surgeon, step by step, how the case is progressing, how the what we are expecting, and how the case is getting ready for the surgery. Any questions?
Thank you so much, sir, for indeed an informative lecture. We'll have the question and answer round at the end of all the lectures, sir. Now we'll have a break for about half an hour, then we'll continue about the lectures. The next lecture is by Dr. Abhilasha Yadav now. We'll continue at 12:30. Thank you.
Thank you, Prasad. Is it okay we take all the questions at the end of the lecture, sir? We have
Fine,
decided
fine.
that only.
Okay, no problem.
Okay, so we will break here for half an hour.
Okay.
And we are running on time. Thank you, sir. Thank you for all of you have made the lecture so well that they are ending at our time, its scheduled time. So we'll again meet here at 12:30.
Okay.
Yeah.
I welcome you all back to the webinar. We'll wait till the other participants join back. We'll wait for 5 minutes and then we'll start with the session of Dr. Abhilasha Yadav ma'am.
Hello everyone, we'll wait for some more time as many people are yet to join. So we'll wait for 5-6 minutes. All right, we are ready to start. We are just waiting for Abhilasha ma'am. She is joining. Yeah, she has joined the meeting. We'll start in a minute. Yeah, she has joined. Over to you, Rishabh.
Yes, sir. Now we'll move on. Now we'll move on towards the next session. Next session will be chaired by Dr. Abhilashi Yadav ma'am. She is head and professor of Department of Oral and Maxillofacial Surgery in Awadh Dental and Dental College and Hospital. She has 23 national and international citations registered to her name in international and national journal. I welcome you, ma'am, for the session.
Thank you so much. At the outset, I would first like to thank our organizing committee for having me here. And good afternoon to all the participants. I hope there are a maximum number of students here. So just let me share my screen. Hope my screen is visible. Is my screen visible?
No, Abhilasha. Yeah. Now it's visible.
Okay. Thank you so much, sir. So good afternoon, one and all. Now, as Prasad sir has again helped me a lot by his presentation. So now we'll be looking at the surgical considerations and the treatment options which are available for orthodontic surgery. Now, just a brief introduction. As we all know that humans are the marvelous balance of harmony and symmetry of various facial structures and proportions. Any discrepancy from the normal alignment makes the person appear worse in terms of aesthetic and surgery done to correct dentofacial deformities are known as orthodontic surgeries. So basically, whatever procedure we are doing in this, which cannot be corrected with the help of orthodontics alone, that is called as orthodontic surgery. So it is done basically in conjunction with the orthodontist. So as rightly said, it's an interdisciplinary work, teamwork. You cannot do it alone. So the kind of treatment available when malocclusion is caused, it can be done in 3 phases, like the groove modification. It can be done in orthodontic camouflage or an orthodontic surgery. Now, basically, by definition, for the students, this is by Raymond Fonseca. It is orthodontic surgery is the art and science of diagnosis, treatment planning, and combining orthodontics and oral and maxillofacial surgery to correct musculoskeletal, dental, and soft tissue deformities of the jaw and associated structures. Now, what is the importance of orthodontic surgery? Basically, people usually recognize malposed teeth or obvious jaw deformities and seek treatment from an orthodontist who can improve tooth alignment, function, and facial aesthetics. But at times what happens is that there are more severe deformities that require a combination of orthodontics and surgery for correction. And they are called as dentofacial deformities. So these deformities can affect the physical orofacial function in several ways, like mastication, lip incompetence resulting in mouth breathing and or drooling of saliva, dental caries and dental disease, temporomandibular functions. There is a psychosocial impact of a dentofacial deformity on an individual is often most paramount. It can profoundly affect the quality of life and entail lifelong adjustment. At times, you may come across individuals who are not so much happy with their appearance that they try to commit suicide also. There, if you take history, proper history, you'll come to know that the patient or the individual whom you are talking has attempted suicide. So you must be very, very, very careful while taking history. And at the same time, a piece of advice: you should not entertain patients like come to you and tell you, मुझे ये हीरो हीरोइन जैसा दिखना है, मुझे ऐसा sharp jaw चाहिए, I want to look like Hrithik Roshan. You should not encourage such kind of patients. You tell them the reality that this is not possible. What better you can do, you can just counsel them. As we all know that it is a triangle where we have a patient, we have an orthodontist, and on the third end we have a maxillofacial surgeon. So basically it is a teamwork. You can alone if you want to go for an orthodontic surgery. As you all know, the golden proportion, the face is divided in some parts. The ratio of upper face height to the maxillary alveolar height is 1. The mandibular face height is 1. So basically the golden proportion is 0.61:1. This can be an MCQ questions in your question paper. Now, what are the basic therapeutic goals of orthodontic surgery? Basically, it is first to achieve function, then the aesthetics, stability, and minimizing the treatment. Because if you see, there is a lot of time required if you consider orthodontic treatment. So you can combine your orthodontic treatment with surgery and you can minimize the treatment time. Now, what are the specific therapeutic goals? You need to correct masticatory and or swallowing abnormalities, establish a functional occlusion, correct associated TNT dysfunctions, pathosis or pain, decrease or eliminate the myofascial pain or headaches. These kind of patients, they do complain of headaches also. Abnormalities related to respiratory compromise, correct speech problems, improve the stability of orthodontic results, improve dental and periodontal health, improve psychosocial elements. There are basic examination like identification of, you need to look for the air basically in cases wherein you find that the mandible is not well developed. There is a retrognathic mandible. In those cases, what you can find is that there is a decrease in the airway space. If you take a lateral oblique X-ray, the lateral skull X-ray of an individual or that patient, you find that the airway is tracheal space. It is very narrow. You can have disorders and pathology conditions. These all things has to be taken into consideration. Facial evaluation has to be done. Your should all photographs needs to be evaluate the patient frontal view, the left and right lateral view, also in 3 views. Right? Then I'll rush through the slides because there are repetitions which I couldn't remove now. So as we all know, rule of thirds, the face is divided into 3 parts. Now, according to the frontal Larry, Woolford and field analysis, the transversal balance includes normal intercanthal distance, which is normally 32 plus minus 3 mm, and interpupillary distance, that is 65 plus minus 3 mm. And again, vertically divided into 5 parts. Now, I skipped because already Prasad sir has told you about these things. Open bite, health of dentition, tooth size discrepancies, curve of spacing, missing, decayed, and retained primary teeth. Discrepancy in centric occlusion and centric relation, periodontal evaluation, as Dr. Satish has already mentioned, then transverse AP or vertical symmetries, anatomic or functional tongue abnormalities, recording of any masticatory difficulties and attrition. Now, if you look, you should also look for the TMJ evaluation. Why it is important? Because this is a foundation for your orthodontic surgery. Any undiagnosed TMJ pathosis, you can have condylar resorption. When you are doing the evaluation of the patient, you can diagnose a patient if the patient is having a condylar resorption, malocclusion, jaw dysfunction, facial deformity. Consider the patient history, polyarthritis, clinical examination, and radiographic imaging. These are the common dentofacial deformities which we come across in our day-to-day practice, like micrognathia, macrognathia, prognathism, retrognathism, chin elongation, gummy smile, incompetent lips, excess teeth. Now, patient presentation, they'll come to you with maxillary prognathism, retrognathism, as we have already discussed. Then the patient can have excess chin, wherein it can be vertical or horizontal. Chin recessive, vertical again or in horizontal plane. There can be a D bite and an open bite or asymmetry. Now, if you look at the maxillary prognathism, there will be a convex profile. If you can see my pointer, there will be a convex profile obtuse nasolabial angle, upper lip will be everted, and excessive dental display will be there. In cases of retrognathism, you'll find that the patient will have a concave profile. See, the patient can have a concave profile. There will be retrusive upper lip, acute nasolabial angle, alar base will be narrow, and there will be lack of dental display. The patient will have somewhat kind of a look of an edentulous patient. Now, if there is a maxillary vertical axis, again there will be a convex profile, lower facial height will be increased, alar base will be narrow, the nasolabial angle would be obtuse, excessive incisor display will be there, lip incompetence, mentalis strain with lip closure. If the patient tries to, if you can see here, this is when the patient is smiling. Even at rest, there will be slight amount of, there will be, lip will not be imposed. So when the patient tries to close lip, there you can see that the patient is having a mentalis strain, and there can be retropositioned or recessive chin. Now in maxillary vertical deficiencies, you'll find that the patient can have a concave facial profile, lower facial height will be decreased, the nasolabial angle will be acute, alar base will be widened, there will be lack of incisor display. As I mentioned earlier, edentulous appearance and chin protruded. In mandibular retrognathism, a convex profile, a retruded chin, lower lip will be everted, the upper lip will be short, deep mentolabial crease and mentalis strain with lip closure. Mandibular prognathism, as in case where we have we can see a class 3 malocclusion. So concave profile, prominent chin, midface appears deficient. There will be steep mandibular plane angle. Lower third will be broad and lower lip thin. I'll just skip this. Thank you, Prasad sir. Now coming to just a minute. Yes, Dr. Achint asked me to incorporate this in my presentation about a small introduction or maybe a small thing about this TAD. TAD basically is a temporary anchorage device, though I don't have personal experience with this. So the images are from internet. So basically TAD, it means a temporary anchorage device, which are small bone pins. So TAD can be defined as a device that is temporarily fixed to the bone for the purpose of enhancing orthodontic anchorage, either by supporting the teeth or the reactive unit, or by obviating the need for the reactive unit altogether, which is subsequently removed after use. Traditionally, orthodontists have used teeth, intraoral appliances, and extraoral appliances to control anchorage, minimizing the movement of certain teeth while completing the desired movement of other teeth. However, because of Newton's third law, that is, for every action, there is equal and opposite reaction. So there are limitations in ability to completely control all aspects of tooth movement. And hence, TAD was used. The success of orthodontic treatment hinges on the anchorage protocol planned for a particular case. So use of extraoral anchorage devices has a headgear which requires full patient cooperation, which at times is not possible. Then introduction of implant in orthodontics has solved this problem. How? The implants have become one of the best sources of reliable anchorage, and many implants have revolutionized the field of anchorage in orthodontics. So basically, this is how it looks. The implant has an implant head and an implant body. On the head, you will find that there is a small hole from which you can even pass your orthodontic wires. Now there is a slot through which you can engage the elastics, orthodontic elastics or your elastics E-chain. The screw basically embeds into the cortical and medullary bone to provide retention. Cutting edge facilitates insertion. Screws are either cylindrical or tapered. Screws are designed as self-drilling and self-tapping types. That means self-drilling and self-tapping means you don't need to drill a hole to insert the screw. You can straight away take the screw and insert it over the mucosa. So these are some of the pictures again from the internet, wherein you can see the indications and applications of this TAD, that is a temporary anchorage devices. It can be used for, as I've been told by the orthodontist, that it can be used for intrusion purpose, for retraction. If you want to retract the anteriors, like you can see here, So for the purpose of retraction, also for if you want to straight, if there is a mesial molar, if you want to upright that molar, it can also be used to upright the tilted molars. This Prasad sir has already explained you. Now coming on to the surgical treatment objectives, that is STO, basically the surgical prediction tracing. So STO is a two-dimensional projection of the osseous, dental and soft tissue changes resulting from surgical orthodontic corrections of orthodontic and orthopedic deformities. Now what is the purpose? So basically the purposes are to establish orthodontic goals, to develop surgical objectives, to create the predicted facial profile. So initial STO and then final STO. The initial STO, you will have to assess for compensation according to skeletal discrepancy, assess molar and incisor position in 3 planes of space, determiners of the anchorage consideration, extraction protocol, and explanation of the same. The final STO is your surgical protocol. Now, diagnostic list, this has already been covered. I would just like to rush through few of the slides because this is important from the point of view of postgraduate students exam. You get a full question on this model surgery. So types, it can be a pre-treatment model surgery, pre-operative model surgery. So pre-operative, to facilitate 3-dimensional measurement of pre and post-operative positioning, to place the jaw models into desired position, to evaluate the feasibility of planned surgical moves, and to construct the surgical splint. Now, orthodontic model surgery basically involves complex 3-dimensional movements of the maxilla and mandible. So a plane of precise surgical moves is formulated to achieve a desired functional and aesthetic outcome based on factors including facial symmetry and balance, occlusion, incisor tooth show at rest and full smile, soft tissue drape, and comorbidities such as obstructive sleep apnea. These surgical moves can be described as translation or rotation, which is called as roll, pitch, and yaw, along the anteroposterior, transverse, and vertical axis respectively. So model surgery, basically the analytical model surgery allows transfer of prescribed 3-dimensional movement directly to the patient, allows surgeon to confirm surgical movement by using maxillary and mandibular cast. It provides a quantitative data that are useful at the time of surgery. The geometrically precise information is then applied to patient by using specific measurements, reference points, splints to reposition maxillofacial skeleton. So basically impressions are taken, a wax bite to record pre-surgical occlusion is done. Then phase bow record or phase bow transfer is done. I'll just rush through the slides. Cast mounted on semi-adjustable articulator. This is how the mounting of maxillary cast with spacers is done. Blue plaster used for initial mounting. This is, in this picture, you can see the jig positioned in articulator. Maxillary cast stabilized with the putty material. Initial mounting and plaster removed. Maxillary impaction. How much maxillary impaction do you need? As Prasad sir correctly told that orthodonticists are the people who can guide the surgeons that we want this movement. We want the maxilla to come forward by this many millimeters, or we want the maxilla to go up, that what we call as a superior repositioning, by this many millimeters. So that can be done on your articulator. Now measurement of amount of impaction, what is required can be done. Auto rotation if needed. This is the intermediate splint which we use during surgery. This is fabricated pre-operatively based on your articulated models cast on which you have done your mock surgery. Mandible advanced to the desired position. This is how the splint, fabrication is done of the final splint. This is a final splint which will be used again in the patient after you do all the osteotomy cuts. If suppose you are doing it for maxilla and mandible both bijaw, then after both the jaws osteotomy cut is done, then you use a final splint, secure it in position, and plating is done after this. Now definitive treatment plan, you have to see for all the dental and periodontal treatment is to be done before the surgery. Extractions, if any, advised like the premolar extractions or maybe impacted third molars should be removed before surgery. Preferably third molars should be removed before surgery. Pre-surgical orthodontics, surgery, then post-operative again orthodontics, definitive periodontal and general dental management. Now, one by one, we'll look into the deficiencies. Like first, we'll come to the maxilla. If there is vertical maxillary excess, the excess is confined to anterior region with an acceptable posterior occlusion. In those cases, the treatment advice would be an anterior segmental osteotomy, which can be a Wasmund or a Wondrous technique, or a Leaford-1 osteotomy is indicated. If there is excess in which is confined to the posterior maxilla, producing an anterior open bite with a normal relationship of the upper lip and central incisors, in those cases, we can go ahead for a posterior segmental osteotomy, or a Leaford-1 is indicated. The position of the mandible produced by its auto-rotation may require a mandibular osteotomy as well. Then, in cases wherein excess involving both anterior and posterior maxilla with or without anterior open bite, in those cases, a Leaford-1 osteotomy is indicated. Now, maxillary vertical excess. As you can see here, the main components of patient with vertical maxillary excess are gummy smile or functional problems caused by anterior open bite, the hallmark of long face deformity. There will be increased total facial height caused by an increased lower facial height, mandible that is rotated downwards and backward, increased interlabial distance greater than 4 millimeters, increased maxillary incisor exposure, except in patients with an open bite. There will be sunken cheek appearance, often a well-developed, almost excessive curled lower lip, narrow face width, excessive maxillary incisor exposure, except in patients with an open bite, increased interlabial distance, often increased vermilion exposure of the lower lip, increased lower third face, there will be gummy smile, depressed paranasal areas. Paranasal areas means this one. So depressed paranasal areas with a likelihood of flat cheek, often an anterior bite, high arch palate with a large distance between the root apices and the nasal floor. There can be a V-shaped maxilla and teeth often in palatal crossbites, mandibular incisors that tend to become more upright and therefore more crowded. Now, in cases of vertically maxillary deficiency, now if there is a deficiency confined to the anterior maxilla with acceptable posterior intercuspation, in those cases, an anterior segmental osteotomy using a Leaford-1 approach is recommended. A bone graft may be used to stabilize the osteotomy. Deficiency involving either posterior maxilla or the entire maxilla. In such kind of cases, a Leaford-1 osteotomy with interpositional graft is recommended. So, okay. In maxillary vertical deficiency is very often associated with maxillary anteroposterior deficiency, in which the maxilla does not develop a forward or a downward direction. It is common in patients basically with cleft lip and cleft palate deformities. You can see here. This is an intraoral photograph of a cleft case. The lower and middle thirds of the face are proportionally reduced in height when the patient teeth are in occlusion. Acute nasolabial angle, appearance of an excessive chin because of overclosure, you can see here. Appearance of an excessive chin. Improvement in profile on mandible is in rest position. Maxillary incisors that are not visible under the upper lip. There will be appearance of a short square face with strong exaggerated masseter muscles. Maxillary incisors that often are not visible with the mouth opening, creating an edentulous appearance, and incisors that are only partially exposed when the patient smiles. When the mandible is closed, the corners of the mouth are turned down, and the skin folds that are apparent lateral to the oral commissure, giving a saddened kind of appearance to the patient. Often a broad nasal base and large nostrils will be there, and appearance of an excessive mandible. Now coming on to horizontal maxillary excess. If the premaxillary prominence with a satisfactory posterior occlusion is present, in those cases an anterior dentoalveolar segment osteotomy with removal of first premolar is recommended. Whereas when entire maxillary arch requires posterior movement, a Leaford-1, standard Leaford-1 osteotomy is the treatment of choice. Now in horizontal maxillary deficiency, advancement of the entire maxilla, when you require that the maxilla needs to be advanced, needs to be brought forward, In those situations, a LE4-1 osteotomy, bone graft for stability is not required for advancement, right? So LE4-1 osteotomy is preferred. Advancement of the malar region can be accomplished simultaneously. A high horizontal osteotomy, LE4, but high horizontal osteotomy. That means when in conventional LE4-1, ideally you take the osteotomy cut from the lateral piriform rim. So in those situations where you need to augment the malar region, in those situations what you do is you take a horizontal osteotomy slightly higher up by implanting only bone graft and alloplastic material. And advancement of the infraorbital rim, if advancement of the infraorbital rim is required, then a LE4-2 osteotomy is indicated. So maxillary anteroposterior deficiency, these are basically the clinical features which you can see in the patient. Sunken cheek appearance, then reduced upper lip length and thin vermilion, flat and relatively short upper lip, narrow alar base, often sclera seen inferiorly of the iris of the eye. Normal to deficient maxillary to lip relationship will be there. Less vermilion exposure of the lip, upper lip, paranasal flattening. Class 3 malocclusion, often crowding in the maxillary arch, often small or absent maxillary lateral incisor. Often there can be normal inclination of mandibular incisors in comparison with the lingual inclination in mandibular anteroposterior axis. There will be tendency of the maxillary arch to be narrow and often in lingual crossbite with the mandibular arch. Now coming on to your transverse maxillary axis, when the maxillary arch needs to be narrowed, you want to narrow the maxillary arch. In those situations, a palatal osteotomy along with LE4-1 osteotomy can be performed. In cases of transverse maxillary deficiency, can be addressed in the pre-surgical orthodontic phase itself in an adult when conventional therapy for expansion is not successful. So what can be done is a lateral maxillary osteotomy through zygomatic buttress on each side is recommended. Now, in cases wherein unilateral expansion of the posterior maxillary segment is required, in those situations, it can be accomplished with a segmental osteotomy. Now, maxillary anteroposterior axis. Again, if you look at the clinical features or the appearance of the patient, there will be general protrusion of the middle third of the face, prominent infraorbital rim and cheekbones, upper lip that is often short and everted, deep labiomental circles because the lower lip curls under the maxillary incisors. There will be lip incompetence, acute nasolabial angle, long face, lower facial height, short curled upper lip, tendency towards open bite, tendency towards a narrow constricted maxilla or a high arch palatal wall. Now coming on to your mandibular deformities. In cases wherein the vertical mandibular excess is there, there will be elongation of the lower third. So it can be corrected by intrusion of the maxilla with or without mandibular surgery, depending on your incisor show of the upper teeth, upper jaw, maxilla. When maxilla does not permit surgery, in cases wherein you cannot go ahead with the maxillary surgery to correct your lower third facial height, in those situations, what can be done is a reduction genioplasty or contouring osteotomy of the lower border of the mandible is performed. Now coming on to your vertical mandibular deficiencies, advancement of the mandible usually results in increased lower face height depending on the mandibular plane and steepness of the occlusal plane. So horizontal genioplasty with interpositional bone graft for lengthening of the deficient mandible may be considered. Now coming on to the horizontal mandibular excess, when the entire mandible is in excess and requires a posterior movement, in those situations, a ramus osteotomy is indicated. It can be a vertical ramus osteotomy or an oblique osteotomy. Alternatively, a sagittal ramus osteotomy or an inverted L osteotomy may be considered. Now, if there is posterior occlusion is satisfactory and the prognathic relationship confined to the anterior segment, in those situations, only an anterior segmental osteotomy is the treatment of choice with extraction of the premolars. Now, when there is occlusion is satisfactory but the lower third is long, in those situations, what can be done is osteotomy of the lower border, which can contour the bone. It can be done. Now, coming on to your horizontal mandibular deficiencies, the entire mandible requires advancement along with dental arch. In those situations, BSSO or the sagittal split osteotomy is the most reliable procedure. Then advancement of mandible with closure of 3-4 mm of anterior bite. Again, sagittal ramus osteotomy may be accomplished with adequate stabilization. Alternatively, an inverted L or a C osteotomy can also be performed. You should know about all these osteotomies, right? L osteotomy, C osteotomy, though they are not more commonly performed these days, but you should be aware of this. When occlusion is acceptable and requires advancement of the lower third, this can be achieved by means of an advancement genioplasty, or what you call as a sliding genioplasty. Now, transverse mandibular excess. If the mandibular arch is too narrow, orthodontic treatment is a primary choice, wherein you can expand. If it requires a surgery, a maxillary narrowing is considered. If the occlusion is acceptable, the deficiency is managed by use of onlay graft or alloplastic material to improve the contour. In cases of transverse mandibular deficiency, if the occlusion is satisfactory, excess width of the mandible is there, it can be corrected by reduction or contouring of the jaw. If there is a relative excess of the mandibular width, that can be corrected by altering the sagittal relationship of the jaw. Now coming on to the procedures, till now we have seen all the deficiencies or discrepancies which are present and what can be done. Now coming on to the procedures, now going back to history, orthognathic surgery of the maxilla was described in 1859 by von Langenbach for the removal of nasopharyngeal polyp. Cheever in 1867 reported a maxillary osteotomy for complete nasal obstruction secondary to epistaxis. He used a right hem maxillary down fracture. Whereas in 1921, Cornstalk described a segmental osteotomy of maxilla, which was modified by Wasmund in 1926 by a labial approach. Cooper in 1954 and Wunderer in 1963 reported a direct surgical access to these procedures, which improved mobilization and maintained the blood supply. These are some of the, again, I'll skip this. Now coming on to the biological basis. Basically, maxilla, it receives its blood supply from branches of the maxillary artery, that is the palatine artery and the superior alveolar arteries. It also receives collateral supply from the branches of the facial artery. Collateral circulation within the maxilla and its evolving soft tissues and the many vascular anastomosis in the maxilla permits numerous technical modifications of the Leafoot 1 osteotomy. So basically, while you're performing a maxillary Leafoot 1 osteotomy, care has to be taken not to injure the blood vessels so as to avoid necrosis of the palate later. Coming on to deformities, we have already seen this: sagittal excess, sagittal deficiencies, vertical excess, vertical deficiencies. So orthognathic procedures, to correct them, we can do some surgical procedures like orthognathic surgery or distraction osteogenesis. Orthognathic surgeries can be for a maxilla, can be for mandible, or there can be bimaxillary procedure, that is involving both the jaws. Now surgical procedures in the maxilla, you can do or go for a segmental osteotomies, Leafoot 1 osteotomy, SARMI or SARPI, that is surgically assisted rapid maxillary expansion or surgically assisted rapid palatal expansion, Leafoot 2 osteotomy, total maxillary alveolar osteotomy. Segmental osteotomy, it can be a single tooth osteotomy, anterior maxillary osteotomy or a pre-maxillary osteotomy, or posterior segmental osteotomies. Now coming on to the maxillary surgeries, basically, again, for the benefit of postgraduate student, you should know the classification. So segmental maxillary surgeries can be a single tooth, a corticotomy can be done, anterior segmental osteotomy. Basically, we have Wassermund, Wunderers, Epker and Wolford, amongst which Wassermund and Wunderers are the most commonly practiced. In posterior, we have Schuchard and Kufner. We also have a horseshoe osteotomy, which was given by Wolford and Epker. Now, if total maxillary surgery is done, then you can go ahead with Leafoot 1, Leafoot 2, Leafoot 3 osteotomies or others. So in Leafoot 1, there is a classical down fracture which was given by Bell, surgically assisted maxillary expansion, in which cases you release the buttress. So buttress is released and expansion can be done. And there is a quadrangular osteotomy which was by scalar and satin. In LeFo2, you can have anterior LeFo2 osteotomy, pyramidal LeFo2 osteotomy, which was given by Henderson and Jackson, quadrangular LeFo2 osteotomy, which was given by Kufner, and in LeFo3, Gillies and Tessiers. Others, we have the zygomatic osteotomies and the malar maxillary osteotomies, which was given by Obergesser. Now, coming on to the basic principles, whenever you are performing a maxillary surgeries, you need to take into account that maximal palatal and labiobuccal periosteum is to be preserved. Preserve greatest amount of soft tissue pedicle and prevent injury to the tooth. So as per the Bell's principle, as long as the maxilla is predicted to pedicle to the palatal mucosa and labiobuccal gingiva and mucosa, there are adequate nutrition pedicles required for LeFo down fractures. Segmentation, stretching of vascular pedicles, and transections of descending palatine vessels have no discernible effects on revascularizations or bone healing associated with LeFo-1 osteotomy. Now, one by one, if you look into the osteotomy, like the single tooth osteotomy, the indication is for the correction of tooth malposition, dental ankylosis, closure of a diastema. The horizontal cut is made 3 mm above the apex of the root to avoid pulpal necrosis. So, in cases wherein suppose the tooth is intruded, you want to move it down. So, in those cases, a single tooth osteotomy can be done. Now, what is the advantages? Reduction in treatment time, lower incidence of dental relapse as compared to a conventional orthodontic therapy. And as you have advantages, but there are some drawbacks also, like injure the adjacent teeth, periodontal compromise of the treated tooth or the adjacent tooth, devitalization of the teeth leading to pulpal necrosis, color change, and root resorption. Anterior maxillary. Now coming on to your anterior maxillary osteotomy, basically two types which are more commonly performed. That is the Wunderman and Wassmann's procedure. Indications basically are for the correction of premaxillary protrusion, deep bite, and anterior open bite cases. So in the anterior maxillary osteotomy is typically performed from a limited vestibular approach. Like you can see here, the incision is given into the vestibule, upper vestibule, labial sulcus. So limited vestibular approach. After making an osteotomy line on the bone, the horizontal and the vertical osteotomies are performed. Like you can see here, this is your horizontal osteotomy cut, and here you can see your vertical osteotomy cut. In the same sitting, the premolar can be extracted, right? Care must be taken not to injure the tooth roots. So in Wassmann's procedure, the blood supply is from the palatal mucoperiosteum. Incision, a vertical incision in the premolar region is given. A small midline vertical incision is given so as to expose the anterior nasal spine and the septum. And extractions of premolar are done. The osteotomy cut, basically it runs into the buccal bone through the socket of the extracted tooth. The pyriform aperture, palatal bone, and nasal septum is detached. Then whatever required repositioning is performed, you then fix the segment with the help of bone plates and screws, and final closure of the mucosa, full thickness mucoperiosteal flap which you have raised is done. In Wunder's procedures, the buccal supply is from the buccal mucoperiosteum. Sorry, the blood supply is from the buccal mucoperiosteum. So incision, a horizontal incision across the palate, posterior to the planned osteotomy site is done like this. And small vertical incision buccolabally at the proposed extraction site. You can extend the incision in the buccolabal sulcus, wherein you are planning the extraction of that premolar. A small midline vertical incision to expose the anterior nasal spine. This is how it is done. It relies on the intact buccal pedicle for its blood supply because we are giving the incision on the palatal side, right? And then whatever desired movement, you can do it and fix with the help of mini plates and screws. Now coming on to your posterior segmental osteotomies, indication for the correction of posterior maxillary alveolar hyperplasia, correction of total maxillary alveolar hyperplasia when combined with a simultaneous anterior osteotomy, correction of bilateral or unilateral cross bites, distal repositioning of the posterior maxillary alveolar fragments to provide space for an impacted canine or premolar tooth. This is how it is done, tunneling via vertical incision. You can see a small incision is given onto the extraction socket, above the extraction socket, and tunneling is done. You should take care that your incision and your osteotomy cut should be at least 5 mm above the root apices. Posterior buccal and parietal osteotomy is done. Pterygomaxillary disjunction is done. Again, while doing a pterygomaxillary disjunction, care has to be taken onto the positioning of your pterygoid chisel. It should be downwards and backward. It should not be upwards, right? Otherwise, at times, if the positioning is not proper, you can encounter bleeding because to the damage of your maxillary artery. So one more technique which is for posterior segmental osteotomy is your Suchart's procedure. It is indicated to correct the posterior open bite or the cross bite and correction of supraerupted posterior segment. Incision, horizontal incision in buccal sulcus from canine to first molar region is given, and again extraction of premolar is performed. Osteotomy cuts, vertical buccal bone cut through socket of extracted tooth, horizontal bony cut through the maxillary sinus wall from extracted tooth region till tuberosity region, because already we have given a labial incision, right? And again, remember, everything should be, your cut incision should be above 5 mm over the root apices. The required repositioning is performed, fixation is done, and closure is done. Now, complications. There can be complications to segmental osteotomies as well. And what can they be? There can be interference of blood supply, thereby devitalization of the segment can occur, damage to the adjacent teeth, orovantral communications, and delayed union. These are few representative cases of segmental osteotomy, wherein you can see the upper anteriors are proclined. This is how the osteotomy cut runs. Upper labial vestibule, then horizontal incision or your osteotomy cut above the apices of the anterior teeth. These are the post-operative photograph of the same patient. This is a case wherein bi-jaw anterior osteotomy was done. That means the maxillary as well as the mandibular anterior osteotomy was performed. Here you can see that there is bimax protrusion, right? The occlusion otherwise is settled. So for this case, what was planned was an upper and a lower segmental osteotomy. Here you can see the cut for the upper segmental osteotomy. Premolar has been extracted. The vertical osteotomy cut is going through the premolar socket, right? After down fracturing the maxilla and bringing it in its proper position, it can be stabilized with the help of mini plates and screws. This is the marking for the incision on the lower jaw for the segmental osteotomy. Here you can see the osteotomy cut again 5 mm above the root apices. The vertical cut is going through the premolar socket, extracted premolar socket. Splints were obviously used. Treatment planning is very important to orthognathic surgeries, and this is how, after achieving the proper desired occlusion, it is secured with the help of bone plates and screws. This is a post-op picture of the same patient, post-op radiograph wherein you can see the plates and screws. Now coming on to the LeFort-1 osteotomy, it is one of the most versatile and most commonly used orthognathic surgery. Now, what are the indications? Basically, LeFort-1 osteotomy is carried out, performed for superior repositioning of the maxilla for vertically maxillary excess cases, inferior positioning of maxilla in vertical deficient maxilla cases, maxillary advancement, especially in cases of cleft palate and post-trauma patients. Why cleft palate? Because in cases of cleft palate, there is a retrusion of the maxilla because of the scarred cleft palate and the palate tissue. So the patients basically have a mid-third or the maxillary which is retruded. In severe mandibular prognathism, to reduce the amount of severe mandibular setback, and in nasomaxillary hypoplasia cases, or you can say the syndromic cases. This is how the LeFort-1 osteotomy is performed. As we've already discussed that it is a teamwork. So when the orthodontist tells us that we need around 5 mm of superior repositioning of the maxilla, so what can be done is, this is called your caliper. gastroesophageal caliper. So with the help of a caliper, intraoperatively after giving an incision, you can measure the desired amount of impaction of the maxilla you want. Then you proceed with your osteotomy cut, a horizontal osteotomy cut, starting from the lateral piriform aperture or the nasal aperture. You go ahead with the osteotomy or separating the nasal septum. And this is your pterygomaxillary disjunction. This is your pterygoid chisel, which is in place. As I've already mentioned, the position should be downwards and backwards. It should be like this, not in the opposite direction. Otherwise, there can be complications. And when you are doing a pterygomaxillary disjunction, you should always place one finger. One hand is holding your pterygoid chisel. With the other hand finger, it should be inside the palate, so as when your assistant is tapping onto the chisel, you can feel the tip of this chisel with the help of your finger of the other hand. So when once you have mobilized or given all the osteotomy cuts, it is designed to separate a tooth-bearing maxillary component along with bone, palate, and superior part of the maxilla. The mobilized segment can be moved in every direction. So once all the cuts are given, you can simply hold the maxilla and you can move it in whatever direction you want. You want to bring it forward, you can stretch it forward. You want to place it up, that is, you want to do a superior positioning, you can take it upward. If you want to bring the maxilla down, you can bring it down, but in the gap, then you need to put bone grafts. So if you pull the maxilla down, you want to do some inferior repositioning. In that situation, what will happen is that there will be a gap in your osteotomized line. So in that place, you need to put bone graft for better stability of the inferiorly repositioned maxilla. This is how it will look. This is the marking for your incision in the upper vestibule. This is after the full thickness mucoperiosteum is reflected or raised. You can see the infraorbital nerves here. You need to be very careful. Your osteotomy cut will be below the infraorbital foramen, starting from your lateral piriform rim. Then with the help of an septal osteotome, you'll do a septal osteotomy. See, all the osteotomy cuts have been completed. The pterygoid disjunction has also been done. Now, with slide, after you have finished all your osteotomy cut, with just slide your thumb pressure, your maxilla should come down. You should not apply undue force or too much force on the maxilla to down fracture. Otherwise, it can lead to unfavorable fractures. Now, after whatever you wanted to do, like you wanted to superiorly reposition, or you wanted to bring it inferiorly, or you wanted to bring forward the maxilla, whatever desired movement you want to do, after doing that, it is secured or held in place with the help of mini plates and screws. And after this, your mucosal flaps are closed. The mucosa is closed with the help of preferably resorbable sutures. Yeah, one more thing. When you give an incision in the vestibule and you are doing a bilateral procedure, what happens is the alar bases, they flare up. The nose will look more widened. So to reduce that, what we do is when we are closing it, before that we take a stitch through the lower lateral cartilages, the alar rim, this incision itself, with the help of preferably a non-resorbable suture, maybe a Prolene or an Ethilone, and then try to reduce the width of the nose before giving or doing a final closure of your mucosa. These are few representative cases of Leaford 1. This is a preoperative image wherein you can see that there is, the lips are incompetent, there is gummy smile. So this was the intraoperative images wherein you can see this is the incision, marking for the incision. Osteotomy, you can see here, as it was advised by the orthodontist that you need to do a 3 mm superior repositioning. So again, with the help of a gastroesophageal caliper, you measure the distance and remove that much amount of bone, right? After giving or completing all your osteotomy cuts, you need to down fracture the maxilla, separate the septum, the nasal lining, everything. See for any bleeding. If there is any bleeding before you close, see to it that you achieve hemostasis properly. And then in the desired, obviously with the help of your splints, intraoperative splints, you cannot work unless and until you collaborate or join hands with your orthodontist, because you need splints, which they are the better person to guide you as to how far you need to move the mandible or the maxilla, and what we require intermediate splint and a final splint. So when we are doing a by jaw procedure, that is a 2-jaw procedure, we need an intermediate splint wherein we do 1-jaw procedure first, put the intermediate splint. According to that, depending on based on that splint position, we manipulate the other jaw. After achieving this, we put the final splint before plating it, and then secure the segments in proper position as in conjunction with the splints, and then fix with the help of mini plates and screws. And then a final closure is done, wherein we give the alar cinch plus a VY closure. If you can appreciate in this image, you must be wondering that we have given an incision like this. So why there is a suture line here? This is because when we do this, the lip tends to curl inside, move inside. So to prevent that, just to give slightly a lip length, we do a VY closure of the incision line. This is the post-operative images of the same patient. This is again one more case, pre-operative images, and this is a post-op. You can compare here. This is your pre-operative image and this is your post-operative image. Now, at times, what can happen is you can just go ahead and do a single jaw procedure. For example, if I need to do a maxillary procedure now, and I think that I may also need to do a genioplasty, but I'm not sure. What happens is due to surgical edema, on table also there is an edema, because of which you are not able to assess the jaw position. So there is no hurry. Genioplasty you can perform under local anesthesia also. So that can be done as a second procedure later on. These are the intraoperative pictures for that same female patient. You can see superior repositioning was done. Now coming on to the complications of free foot 1 osteotomy. There can be injury to the Stenson's duct. Why? Because if you are not giving your incisions properly, the Stenson's duct, which opens opposite to your second molar, you can injure that. So there can be injury to Stenson's duct. Infraorbital nerve traction injury can be there. Unanticipated fractures, that is pterygoid plate or sphenoid bone fractures, can occur. Injury to maxillary artery and its branches I've already mentioned. There can be lacrimal duct injury or vascular necrosis if your blood supply is gone. I mean, if you have injured your blood vessels. Maxillary sinusitis, villopharyngeal insufficiency. There can be speech problems after your orthodontic surgeries as well. Then nasal septal deviation can be there, and flaring of alar base, which I have mentioned, which you can correct intraoperatively only by passing alar cinch sutures. Now coming on to your mandibular orthodontic procedures, there can be ramus procedures, body procedures, subapical body procedures. Now the commonly used ones are sagittal split osteotomy, vertical ramus osteotomy, anterior subapical osteotomy, and genioplasty. These are the different procedures which are listed there. You can just take a note of it for the ramus procedures, body procedures, subapical procedures. But the commonly used ones are your sagittal split osteotomy, vertical ramus, anterior subapical, and genioplasty. And rarely used are body osteotomy, total subapical osteotomy, midline osteotomy, inverted L or C osteotomy. And obviously genioplasty, as I've already mentioned, it can be done as a separate procedure later also, or it can be combined with if you're doing a bi-jaw procedure, that is BSSO as well as refoot, you can combine your genioplasty in the same sitting as well, or you can do it separately. Now again, for the benefit of postgraduate students, just a classification. I'll just rush through them. Ramus procedures, body procedures, sorry, subapical body procedures, genioplasty. You have these numbers of ramus procedures, which we have already mentioned there in short. Now coming to your condylectomy. So when do we go for condylectomy? Indication is when you have a condylar hyperplasia or active tumor of the condyle. Now coming on to your intraoral vertical ramus osteotomy, or also called as IVRO. Basically, it is vertical subsigmoid osteotomy. It was given by Cardwell and Letterman. Subsigmoid. This is your sigmoid notch. So basically it is a subsigmoid osteotomy. Sorry. Coming on to your inverted L osteotomy. These slides I have included so that you should be aware that these are also the procedures which can be performed. But most widely performed procedure in the mandible is a BSSO. This was introduced by Trauner. Indication for large advancement more than 12 millimeters and mandibular setback of 10 millimeters or more. C osteotomy. So C osteotomy, it will look something like this. Difficult to perform, right? So it is a modification of inverted L osteotomy. Difference is in the osteotomy cut. It is she-shaped horizontal cut just above the level of inferior alveolar nerve towards third molar region. Small vertical cut through inferior border of mandible. Now coming on to the most widely performed BSSO, bilateral sagittal split osteotomy. It is the most versatile and most commonly used technique of all mandibular osteotomies. Principle: natural plane of cleavage between buccal and lingual cortical plate of ramus used to develop sagittal split separating the proximal. Proximal means your condylar segment and distal means dentoalveolar fragment, right? So no confusion. Proximal is your condylar segment, your this segment. Sorry. This is your proximal segment. This is your distal segment. Just remember dentoalveolar segment, D for dentoalveolar, D for distal. Students, they tend to get confused when we ask them during Viva. That's why I just trying to make it easy for you. So indications, basically for mandibular prognathism, minor mandibular asymmetry, cleft osteotomies, Bimax procedures, compensatory repositioning of the occlusal plane, contraindications in severe decreased posterior mandibular body height, thin mediolateral width of ramus, severe ramus hypoplasia, and severe asymmetries. So historical review, basically this was by Trauner and Obwegesser. So horizontal cut just above the mandibular foramen or medial side of ramus, on medial side of ramus. So just above the mandibular foramen. Vertical cut down the anterior border of the ramus, oblique cut through lateral cortex towards the angle of the jaw. This was by Dalpund. So advanced oblique cut towards the molar region, making the vertical cut through the lateral cortex. So this was a difference between Obwegesser and Dalpund. This was by Hansuk, wherein he shortened the cut through the medial cortex of the ramus by extending it only as far as the mandibular foramen. Now coming to the procedure of bilateral sagittal split osteotomy, surgical procedure. Incision, again you give a mucoperiosteal, you raise a mucoperiosteal flap, you give a full thickness mucoperiosteal incision over the anterior border of the ramus like this. Palpate the anterior border of the ramus, the coronoid process, and extend anteriorly along the external oblique ridge till the first molar region, right? And then with the help of your periosteal elevator, reflect the flap. Then after you have full visualization of your field, then you proceed for your osteotomy, right? This is your lingula. So and mandibular foramen. Lingula will be somewhere here. This is your mandibular foramen. So your osteotomy cut should be above this so that you are not damaging your inferior alveolar nerve. Dissection is done subperiosteal, laterally over the body of the mandible to the lower border, medially just beyond the lingula. Oh, sorry. Can you see here? This is your prominence projection, which is your lingula. So just beyond your lingula, superior to the exposed coronoid process. You come onto your external oblique ridge till your molar and give your vertical horizontal cut. Now horizontal cut, medial aspect of ramus above mandibular foramen. Osteotomy cut is given on the external oblique ridge. Vertical cut, third molar region from external oblique ridge to inferior border of the mandible. Unicortical up to medullary bone. You need to give your osteotomy cut unicortical up to the medullary bone and bicortical just at the lower border of the mandible. Okay. And it is performed bilaterally. Hence, it is called as BSSO, bilateral sagittal split osteotomy. So, after you have done or given your osteotomy cuts, with the help of an instrument which is called as Smith's spreader. You place your Smith spreader into this and try to open it. You are not supposed to apply too much pressure. It should be very gentle. And one more question which is asked in your Viva is, they can give you a mandible and a Smith spreader, and they can ask you how the Smith spreader is applied. So basically, Smith spreader, it is a 3-pronged instrument. 2 prongs on one side, 1 beak or a prong on the other side. So what I was taught, again, there can be different school of thoughts. What I was taught was that the 2 beaks or the 2 prongs, they are towards the lingual side. The theory or the logic behind that is because your lingual bone is thin. So if you put 1 beak on the lingual bone, the pressure or the force which you are applying will be transmitted on a single point, which can lead to fracture of the lingual cortical plate. So as to avoid that, you put your 2 beaks towards the lingual cortex and single beak over to the buccal cortex, because buccal bone, it is thick. So Smith spreader is used to slightly split the osteotomy cut, and then it is mobilized with required movement. If you want to do an advancement or setback, whatever it is there, it can be done. And after that, it can be fixed with the help of bone plates, mini plates and screws. And as we have discussed for maxilla, again, closure is done with resorbable sutures. This is how it will look. Whatever movement you want to do, you want to bring the mandible forward, or you want to move the mandible backward, you want to slightly move the mandible lower down, it can be done. So bilateral sagittal, it divides the mandible into 2 smaller condyles bearing segment and large segment consisting of a mandibular body, including the teeth and the chin. So proximal and distal segments. Universal procedures for all mandibular movements, as we have already discussed. These are few representative cases of BSSO. Basically, this was a bi-jaw case. So you can see your osteotomy cut for the maxilla, and here you can see, before you start giving your external oblique ridge, cut over your external oblique ridge, what you can do is a postage stamp technique. You can just mark with the help of, for beginners, it will be advisable to do this. You can do is, what you can do is, with the help of a round burr, you can just mark like this, and then you can start connecting these dots. Sorry, you can start connecting these dots. It will be like this. So your osteotomy, horizontal osteotomy, complete your vertical osteotomy with the help of Smith spreader. Just try to move them. Place your Smith spreader into the sagittal split and try to separate them. And whatever movement is required, either bringing it forward or moving it backward, can be done. Place your splints, put the patient under IMF, secure the jaws in proper position, secure the mandible or the maxilla, the bone which you have moved in proper position with the help of your mini plates and screws. This is again another case wherein a bilateral sagittal split osteotomy was done. You can see a prognathic mandible here. This is post-operative, a result of the same patient. These are the pre-op and intra-op pictures for the patient. This was pre-surgical. This is post-surgical. Obviously, again, orthodontics was done. As you can see here, intraoperatively, you can see the braces. This is a osteotomy cut for the bilateral sagittal split osteotomy. Herein, you can see the exposure, nice ramus of the mandible. You can see the external oblique ridge. After doing a desired movement, setting the mandible back, you can secure with the help of your mini plates and screws. Now, as we have seen some complications with the the anterior subapical osteotomy, there are complications associated with BSS also. So what can they be? There can be injury to the inferior alveolar nerve. Very, very, very important. You need to take care that your inferior alveolar nerve, if I may ask the postgraduate students present here, your inferior alveolar nerve should be in which segment? Proximal or your distal segment? Proximal or your distal segment? Just to make it easy for you, I'll show you this picture. Yeah. So your inferior alveolar nerve should be in your proximal or your distal segment. If you can just type your answers in the chat box, it will be good. And just to continue, it should be in your distal segment, that is your tooth bearing segment, right? So there can be chances of injury to the inferior alveolar nerve, bleeding from the inferior alveolar artery. In that case, what you're supposed to do is, if you can see it, a spurter or a small bleed is there, what you can do is just apply pressure for some time and hemostasis will be achieved. You can also use agents as in botroclot or gel foam or gelatin foam to arrest the bleeding. There can be unfavorable splits. So you have to be very careful while giving your osteotomy cut so as to avoid unfavorable split. Again, while using your Smith spreader, you have to be very gentle. Don't apply too much pressure, otherwise you will land up in this problem or a complication. There can be avascular necrosis again if you are injuring your inferior alveolar artery. Condylar resorption can take place. There can be a malpositioning or malunion of the segments. Now coming on to your vertical ramus osteotomy, this I have again included it in very short indications, basically in patients with horizontal mandibular excess or mandibular asymmetry. Contraindications, advancement of distal tooth bearing segment or recent condylar fractures. Now advantages are, it has a much lower incidence of permanent inferior nerve injury when compared to BSSO. And disadvantages, may be difficult to control the position of the condyle, healing time, and difficult to use rigid fixation intraorally. Now coming on to the last entity, that is your genioplasty. Surgical technique used to alter the size and morphology of the bony chin with concomitant changes in surrounding tissue. It is also called as mentoplasty. We won't be going into and read it. Applied anatomy, you should take care of your mental foramen and nerve because major sensory innervations of chin are from them. Then mentalis muscle provide major vertical support to the lip, lower lip. Lingual muscle pedicle, again a major blood supply to osteotomized segment of the chin. Root apices of incisors, osteotomic cut should be at least 5 mm below the root apices. Indications are for aesthetic and functional reasons. Macrogenia, that is large chin, vertical, horizontal or combination. If there is microgenia, that is small chin, then vertical, horizontal, again combination, or in asymmetric cases. In functional chin deformities, chin ptosis or lower lip incompetence cases, you can go ahead with genioplasty. Transoral genioplasty procedure, again, you can give an incision in the labial sulcus, the lower labial vestibule. Dissection is that you try and separate the mentalis muscle. Subperiosteal dissection is done. Horizontal osteotomy, 5 mm below the root apices. Down fracture and reposition. Fixation with the help of mini plates and screws, and closure is done. So this is how it is done. You can go ahead with a sliding genioplasty or a double siding genioplasty as well. These are the images for genioplasty. The standard osteotomy to correct genial deformities is a horizontal osteotomy cut. You can see here 5 mm below the root apices, which allows 3-dimensional movement of the chin. You can move the chin in any dimension, any direction which you want. And after achieving the desired position, it can be fixed with the help of mini plates and screws. Now, complications of genioplasty, you can injure the mental nerve. There can be malunion or non-union, bony irregularities, step-type deformity, lip drop, chin ptosis, and gingival recession. Cole procedure, it was indicated for correction of anterior open bite, anterior subapical osteotomy, genioplasty, and grafting of bone wedge was done. Now coming on to distraction osteogenesis. Basically, distraction osteogenesis is a biological process of new bone formation between the bone segments that are separated by gradual traction. So what is difference is, the procedure is same. You do osteotomy, you perform your osteotomy, you give your horizontal vertical cuts in the same direction, but you don't fix it there with the help of mini plates and screws, but instead you put a distractor. A proper vector has to be achieved for that occlusion. The vector has to be parallel to the occlusal plane. So after placing the distraction, you can try and regenerate new bone. You can form new bone there. So this is basically wherein orthognathics, with the help of orthognathic surgery, you cannot achieve so much of advancement. And it helps to generate both hard and soft tissues, that is bone and soft tissues. So after a suitable latency period, the ramus is distracted at a rate of 1 mm per day. After reaching the desired distraction, the device is left in place to retain distraction and to allow bone for consolidation. So for that much time, the distractor stays in place. This is intraoral distractor. You do have extraoral distractors also. This is called as RED, rigid extraoral distractors. Not used by many. Intraoral are the ones which are commonly used, and you require a separate procedure or a second surgery to remove the distractors later on when you have achieved the desired result. These are few representative cases. This is a case of TMJ ankylosis. Most commonly, distraction is done for TMJ ankylosis cases. Initially, what people used to do was remove the treat the ankylosis first, and later on go ahead with your distraction. But then it was seen that it was very difficult to control the segment. So nowadays what is practice is you go ahead with distraction first and then release your ankylosis. So this is a preoperative photograph of a case of a TM joint ankylosis. See here, you can see these patients, we were talking about airway, right? Can you see here the tracheal space? It is reduced so much. These patients usually have obstructive sleep apneas. This is an extraoral incision for the placement of distractors. You give an osteotomy cut. These are the distractors which are placed. It stays like this. The pin will stay here. Once when you start opening it, the bone, the osteotomic segments, they start moving away from each other and new bone formation occurs between these segments. This is the consolidation phase. You can see here how much amount of opening has been achieved. See here, can you see these pins are in, they are touching each other right here. On the OT table, you can see these two pins, they are touching each other. Now, after we have given one turn every day, distraction opening was done, this much bone formation was achieved. You can see the hard tissue as well as soft tissue is formed. And see, these two pins are so much apart now. So this much of bone, new bone has been formed. This is in the consolidation period, after which you can remove the distractor and later the patient will look like this. Now, can you see here, there is an improvement in the airway space as well. This is a pre-op, this is a post-op. Look at the chin. Preoperatively, the chin was like this. Now see here. Obviously, the patient will require definitive genioplasty or some other treatment in the later date, but just compare the pre-op and the post-op pictures. This is again one more case of distractor. See here, retruded mandible. This is the same patient after distraction, post-operative photos. Now coming on to recent advances, as far as already told, rushing through the slides, we have virtual planning softwares. Then there can be digital fabrication of occlusal splints as well. 3D virtual immediate and final surgical splints, occlusal splints designed with occlusal relationship in final position. There can lateral attachment sites on left and right sides of the splint, and attachment for maxillary drilling guide. So with this 3D splints, there is also drilling guide available, which helps the surgeon. It makes our job very easy. These are the drilling guides. These are the attachment for the drilling guide from where we need to drill. So bone foot plates are designed with anatomically contoured struts. Split foot plates attached precisely to lateral attachment on occlusal splints. The bone foot plates have two large diameter opening and designed to fit the metal drill guide. This is how it is placed. This is how it is fixed. And you have a guide, drill guide, or you have an osteotomy guide also where you need to put your osteotomy cuts. So drilling and positioning of proximal segment is done with similar concept. Assist in maintaining. So it can be for mandible also and for the maxilla also, both jaws. It prevents lateral torquing of condyles, precise repositioning of large advancements. This is how it is for the mandible. You can see diagrammatic representation for the mandibular drilling guide, and you're fixing the splints or pins. Then you have stereolithography, wherein you can get a 3D skull image. If you want a mandible, you can get a 3D image of the mandible. You can have that in your hand while you are operating. It can be autoclaved, so you can take it to the operation theater. After sterilizing it, you can have a look. You can adapt your plates accordingly onto this. This is how the 3D printer prints your 3D model. Then you have your 3D photography also. Current concepts, surgery first approach. In most of the cases, what happens is the orthodontic procedures, it takes a long time, or like Dr. Prasad was telling us, some patients, they come at a very late age. And like Dr. Satish was mentioning about the patient wanted to get married and there was no time. So in those kind of situations, what can be done is a surgery first approach can be utilized, but you have to continue orthodontics after that also, because even after surgery, you don't get the proper occlusion. So that can be achieved later with the help of orthodontics. Then you have distraction osteogenesis, which we have already discussed. Imaging versus 3D volumetric analysis. Now coming to conclusion, I know it has been a very long topic. Anyways, coming to conclusion, orthodontic surgery is a treatment of choice for patients in whom growth is completed. Please remember this. You cannot do this unless and until the growth spurts are over. So it is done in patients in whom growth is completed, or for those who have a severe skeletal discrepancy. It should be noted, however, that the results of surgery with regards to stability, skeletal and occlusal relapse are highly variable. Now, these are few questions which I have collected for you people. This is basically questions which are coming in your final exams, full questions, essay questions. So if you want, you can just take a screenshot. And these are the references. Again, you can take a screenshot for where you can refer all these books for orthodontic surgery. And thank you for your listening. Thank you so much. If there are any questions, Achin, I think we can take them now.
Yeah, we'll take them later on. We'll ask the participants to put the questions in the chat box. We'll take them.
Okay, sure.
Thank you, ma'am, for the informative insight into the surgical considerations and treatment approaches in ortho-perio relationship. As a token of appreciation, we would like to present you with the certificate. Kindly accept it, ma'am.
Thank you so much. Thank you.
All the queries will be answered at the end of the webinar. Please ping them in the chat box. Now, I would like to invite Dr. Prasad Konda, sir, for enlightening us about the topic adjunctive orthodontics. Over to you, sir.
Yeah, thank you. Yeah. Are you able to see my slides?
Yes, sir.
Yes, sir. Yes, sir.
Yeah, thank you so much. Chint, I think we are running short of time.
I've taken all the time. Sorry for that. I overshooted.
Thank you very much for your patience. Since morning 9:30. I'll just brush up. It will take about 15-20 minutes. Not much of in case of your adjunctive orthodontics. Okay.
Yes,
a very good afternoon to you all. We just rush up with adjunctive orthodontics. What do you mean by adjunct? The dictionary meaning of adjunct is nothing but a thing is added to something else as a supplementary rather than essential part. We see come across such situations in many cities nowadays, right? These structures which are placed, they called as adjunct structures. Can you see these yellow structures for the high-rise buildings? And these structures are called adjunct structures. And they should be a road laid next to the flyover which is constructed. Generally, it is not done in many parts of the cities in India, but this has to be smooth for easy flow of the traffic. These are called as an adjunct things which are done before going for a main structure to build up. Similarly, a patient may come to an orthodontist or not, but generally they approach to a general dentist for some other issues, maybe a missing tooth or a mesially tilted tooth or a supraerected tooth or irregularly spaced teeth. So in such cases, they want conditions to be restored. So in order to restore such situations, we orthodontists need to involve for some time for the betterment of the functions and aesthetic of the final outcome after the restorative procedures, maybe a prosthetic restorative or a perio-restorative procedures. So adjunctive orthodontics is nothing but a tooth movement to be carried out to facilitate other dental procedures, like to control the diseases. For example, if you have a mesially tilted molar, you have a deep pockets in the mesial side of your molar. In order to control such situations, we need to upright that molar. This is nothing but it comes under a part of adjunctive orthodontics for uprighting of the molar. Similarly, when you want to place an implant at that site, you need to upright and you reposition the tooth. So such procedures are called as an adjunctive orthodontics. So this is helpful for the facilitating the other dental works to carry out, whether the prosthetic work or your perio-surgical work or any other work. So which is limited in time and scope. We have a specific goals how to carry out such procedures. So these will come mainly in case of your adult patients only. So why? Because these patients will come with the loss of tooth, maybe long back, they got it extracted sometimes back, long back, maybe about 3 years or 4 years. They didn't go for the replacement of the tooth, which has been extracted due to some various regions or badly caries or whatever is it. In such cases, adjacent teeth definitely move into the edentulous spaces. Now, how to restore this edentulous space with the proper implant or proper prosthesis? In such cases, the adjacent teeth should be positioned properly. So in such cases, we need to intervene with the help of your braces in case of your adult patients. So for many years, orthodontic has been used mainly as a treatment of choice for the aesthetic purpose only. So which is called as a comprehensive treatment procedure. That is nothing but orthodontics has to be done for the aesthetic purpose. Generally, especially in case of your teens and early adolescents or very early adult people, which generally used to come for the whether for the decoding of the teeth or maybe the placed forward or proclined teeth and all. So nowadays the scenario has changed. Many adult patients are becoming aware of the dental hygiene, and they are becoming very much interested to get the replacement of the missing teeth to be done, and they want to look more pleasing rather than, I can say. In such cases, we need to have a multidisciplinary approach. It's not just an orthodontics as well. We need to have an intervene of your prosthodontist or a periodontist or an oral surgeon. So such orthodontics for the adult patients can be used as an adjunctive tool for restorative purpose, a prosthodontic and a periodontal purpose. So this is nothing but a multidisciplinary dental treatment where involvement of 2 or more specialized dental faculties may be involved. So what are the things which are required for such cases? We need to maintain the traditional ortho records, which generally we will take for the patients who walks into the ortho office, like your lateral cephalogram, orthopentomogram, right? Study models, photographs, traditional radiographs, traditional records of all the ortho records which are required for such cases has to be taken. Additional radiograph may require to confirm the presence or absence of your caries or a perio disease. In such cases, like maybe IOPS or a bite wing radiographs or some occlusal view radiographs. So what are the indications of this adjunctive orthodontics? One thing is your pre-prosthetic positioning of the tooth. If the patient is planning, we'll see the different conditions. A patient is planning for an implant or a fixed partial denture. Before pre-prosthetic positioning has to be, the adjacent tooth or abutment teeth should be positioned well in the jaw base for the placement of your appontic. Alignment of the teeth in case of your traumatic occlusion has to be done. Forced eruption, if there is any subgingival caries or a fracture of the tooth is there. In order to restore such fractured tooth, we need to have the forced eruption. Intrusion in case of your extruded tooth. Orthodontic extractions may be required. For example, orthodontic extraction. For example, if you have a tilted, rather I can give an example of missing lower six. There's a chances of mesial tilt of your 7 and 8, which are there distally. In order to upright, if you're planning to upright the 7 and 8, and you want to go for the placement of an implant, in such cases, uprighting both 7 and 8 might be a difficult. So many cases, we advise the extraction of your third molar and uprighting of your second molar and the placement of your implant at the region of your 6th or maybe a prosthesis. Alignment of an anterior teeth for space distribution. These can be seen in many cases where you have a missing lateral incisors, where you have a space is not properly distributed between your centrals and the canine. In such cases, we need to align the anterior teeth properly for the placement of your implant in the lateral region. So what is the sequencing in case of your adjunctive orthodontics? Nothing. First thing is your comprehensive treatment plan. We need to check out the plan. We need to put it on a paper, what exactly to be done. If the patient is involved periodontically, then we need to restore. If the patient is seen with a horizontal bone loss, we need to restore the perio conditions initially with the help of your flap surgery and the bone grafting, so that to stabilize the teeth, to reduce the mobility of the teeth, then you have to plan for orthodontics. When you are planning for the orthodontics, how the space has to be distributed, we need to plan that. So then second thing is your disease control. The patient hygiene has to be maintained. The patient should not have any plaque accumulation or calculus accumulation, so that the bone loss will not exaggerate. We have to re-evaluate the case, how the patient is following the treatment protocols, and how the patient is maintaining the hygiene, and establish the occlusion with the help of the orthodontics with the teeth which are there. With the teeth which are there, try to get the cusp to embrasure relationship. Then you need to stabilize the condition for some time, maybe about 3 to 6 months. Then definitive perio or restorative treatment has to be followed. Definitive perio and restorative treatment has to be followed. And you need to have maintenance of that. Maintenance of the patient is again plays an important role. We'll see the conditions one by one. So we have a molar uprighting. So the direction of the forces or distribution of the occlusal forces is very important in case of your molars, because these are the main teeth which help in the case of your mastication. The direction of occlusal forces and how the distribution is done onto the forces, that is nothing but your root surface area, how they are taking up the occlusal forces, we need to calculate and we need to plan. Decrease the possibility of endo, perio, or other tooth complications has to be there. Increased restoration and durability eliminates the plaque retentive areas. We need to have the restoration of your plaque retentive areas has to be eliminated. Improves the alveolar contour, crown root ratio. With molar uprighting, what will happen? You will have an improvement in the crown root ratio. So what are the considerations, when you're doing a molar uprighting? You need to consider for the incisor positioning, that the crowding of the, whether there is a crowding in the anterior segment. You need to consider for the overbite and the overjet, proclination, and midline considerations. For example, if you're having a molar tilted, and which is the space is very less, and you want to upright and mesialize the molar, and you want to decrowd the anterior teeth also, then that amount of space that is available between your 5 and your 7, it will be utilized for the decrowding of anterior teeth as well as your mesialization of your molar. How much is the anchorage support will you going to get with the molar uprighting? We need to consider space present and the status of edentulous area. How is the status in the edentulous area? Whether it is feasible for the placement of an implant or it is not possible for the placement of an implant. If the space is very less, the amount of space is very less, when we can upright and mesialize the molar. Distal crown movement versus mesial movement has to be judged. So how the bone distal to that molar? How is the bone mesial to that molar? We need to judge whether distal movement is possible. We have an distally, we have an 8 and 7. In such cases, whether it is distal movement is possible, or what you are supposed to do is you mesialize your 7, mesialize your 8. Will leave the possible. All this consideration has to be taken into consideration when you are planning for a molar uprighting. So easier to tip crown distally. So it is easier to tip crown distally. Is it like that? Molar will try to extrude. When you are tipping the crown distally, definitely the molar will try to extrude. In such cases, we need to include the intrusion mechanics. That is nothing but your crown reduction technique has to be followed, or intrusion mechanics has to be followed, so that the occlusal plane has to be maintained. The premolar alignment, just check for the premolar alignment, how they are there. Is there a spacing will be affected with this molar uprighting distally, or how molar uprighting and you are moving the molar mesially? We need to check for such things. If it is mild tipping, so we'll consider this mild tipping and a severe tipping. If it is mild tipping, we don't require much of special mechanics. You have a continuous leveling arch wire. So this leveling arch wire will be extended up to the molar, which is tilted. So with the help of your super elastic wires, whether night-eye or rather we can use a stainless steel wires with a push coil spring, that is nothing but open coil spring, that mild tipping can be corrected. So we need to reinforce the anchorage unit. Idle bracket positioning is important. So how to reinforce the anchorage unit? In the case of your molar uprighting, here the molar will not act as an anchor unit. So anterior teeth, you stabilize them from premolar to premolar. This entire thing will act as an anchor unit, which will help for the uprighting of your molar with the help of your super elastic wires, or in case of your stainless steel wires with the help of your open coil springs. So this requires a relieving of an occlusion. So when you have this molar tipping, we need to relieve the occlusion. This should not be intercuspation should be present. When you have an intercuspation, even if you give it for 6 months of time, then there won't be molar tipping will not be get corrected. In such cases, just raise the bite in the opposite side by giving a bite blocks. So, or giving a posterior bite blocks or anterior bite blocks, just raise the bite and relieve the occlusion. So it will have free to erupt. If it is severe tipping, then we need to use a rigid wire with an anchorage units plus auxiliary springs. So base wire will be there. Along with that base wire, we need to have an auxiliary springs, which can be made from 1925 stainless steel wires or 1725 TMA wires. Molar tend to extrude, definitely. Anchor unit tends to procline and intrude. So here is an anchor unit, as I told you, which will be an anterior teeth. So anterior teeth, you have to stabilize and increase the root surface area so that the entire unit in the anterior segment act as an anchor unit, which will help for the molar to upright. So during that tendency, there is a tendency of extrusion of a molar during uprighting. So we need to intrude the molar. You have to give the intrusion mechanics to the molar so that it will be maintained at the occlusal level. So bend back wire will be provided for the mesial movement of your, for example, if you want to upright and mesial movement of the wire has to be done, then we need to bend the wire or cinch back the wire at the distal to the molar tube. So we need to retain after a uprighting. Relapse can occur quickly. We have a very strong transeptal fiber. There is a chances of relapse even after a mild or severe tipping, which has to be uprighted. The relapse will be there very quickly. We need to retain them. So retain till what time we need to retain them? Till the prosthesis has been placed, whether it's with the help of an implant or a fixed partial denture. So we'll see a couple of conditions where, for example, you have seen the 6 has been lost over here. Your 7 is tilted. So the 6 has been lost. 6 is lost along back. Can you see the occlusal surface of your upper arch? Even your molar has been supra-erupted. In such cases, what you're supposed to do, you strap up your upper arch, intrude this molar to the occlusal plane. In such cases, if this mild tipping is there, you strap up the entire anterior segment, just attach your buccal tube or your band your buccal tube. If it is not happening with the regular orthodontic mechanics with the base wire, we need to give an auxiliary mechanics. So a couple of mechanics which generally follow is your placement of your tats distal to the molar. Give a lingual buttons which are attached on the lingual side, buccal side, as well as the mesial side. Give an E-chain, elastomeric chain for the uprighting of your molar. This is one technique which can be used without involving the entire, without strapping up your anterior, in the anterior segment or upper arch. In such cases, where you can follow a segmental mechanics. Can you see these hooks? The bite has been raised over here. So here the premolars and the canine has been strapped up. They have given a segmental archwire. They stabilized and increased the root surface area as an anchor unit. So roots of your canine, first and second premolar is acting as an anchor units for uprighting your molar, which is tilted mesially. So as I told you, if you have a mild tilting or mild mesial movement of your molar, so what you can use, this is a regular base arch wire, a stainless steel wire with the help of a push coil spring has to be placed, open coil spring has to be placed. So when you want to, when you're trying to upright, don't cinch back this wire. Don't cinch back this wire. When you're trying to cinch back this wire, the vertical movement or distal movement of your tooth will be get restricted. So again, one more thing is you have a base arch wire, you have an auxiliary wire which is tilted mesially. A copper night eye or a night eye wire can be placed so that your uprighting of a molar which is tilted mesially can happen. So many cases where they come across, your prosthetic friends might refer to you. So I want this uprighting of your molar so that I'm planning for an implant process is there. So when you're after uprighting, you have a sufficient space for the placement of an implant. So later your prosthodontist will plan for the placement of an implant, which one he wants to go later. So pre-prosthetic alignment, when it is required, so it can be done with the help of your fixed appliances for the redistribution of the spaces, a leveling and alignment, or can be done with the help of your removable appliances nowadays called as aligners. A limited number of aligners can be used, which are very much aesthetic and very much user-friendly nowadays. Pre-prosthetic alignment can be carried out with the help of aligners. So these are the indications for the perio and restorative purpose, for the better gingival architect and easier for the tooth preparation or tooth positioning. So when you come across conditions like this, there's the uneven distribution of a space. This lateral is congenitally missing. You have a midline diastema. So we don't have a sufficient space for the placement of an implant in the lateral region. So what you're supposed to do? When you are supposed to strap up your entire upper arch, get the centrals together in the mesial direction, close the diastema, maintain the root parallelism, open the space for the lateral to place, for the placement of an implant. So can you see here, the space has been sufficiently opened and place an implant for the lateral incisor. Later, a crown is placed on the implant. So this is the done in case of many cases we'll come across like this. So some cases we may come across, for example, missing laterals are there. So in such cases, instead of distributing widely, the canines are very much near to here. The space is occupied with the space is available distal to the premolar. In such cases, what you do is you mesialize your canines, make them as your lateral incisors. This premolars will act as a cuspids. For the cuspid guidance and all, you need to plan the cuspids. Then you need to place an implant in the premolar region for the placement of your premolar teeth. So as I told you, redistribution of the space can be done with the help of your fixed mechanics or with the help of your aligners. Aligners are like this. In this, you can place a pontic, which is tooth colored at the time of aligners, so that you, for example, you have crowding is there. The crowding will get relieved. By the meantime, the patient is aesthetically, it's not pleasing in the anterior region, which is just a big window which is seen. In such cases, you can place a artificial tooth, so till the type of aligners. So gradually the size of this will be manageable in the periodic aligners. So forced eruption. When do you carry out a forced eruption? When you have a fractured tooth, or when you have a caries crown involving a cervical third of the root. So in such cases, when you want to restore that cervical third, so it is not possible, which is just below the gum marginal gingiva. In such cases, we need to forcefully erupt, or forced eruption has to be done, restore the teeth and restore the crown. If you have fractures, then you have to supposed to erupt. They have different techniques for the forceful eruption. So one more thing is, if the endodontist is planning to perform a root canal therapy for your fractured tooth, so placing of rubber dam is not possible in such cases. So you need to extrude a little bit, maybe about 4 millimeters above the crestal bone. so that your rubber dam can be placed by your endodontist. So which will allows the adequate tooth structure to be exposed for the restoration purpose. It will reduce the period defects. What type of period defects? If you have a bony pockets or a deep pockets, forced eruption will reduce the pocket depth. In such cases, your bacterial count will reduce and the patient can maintain a healthy gingiva. Localized effect does not compromise bone support to the adjacent teeth. In healthy individuals, bone and gingiva follow your dental movement. So as I told you, tooth should be erupted at least 4 millimeters above the alveolar crest. So what is important in such cases is your importance is nothing but your crown to root ratio is very important. So we need to calculate how much is the root surface that is there within the bone. Will it be sufficient? Will it be sufficient when you are forcefully erupting the tooth? Will the function load of your occlusal forces will be taken by the root or not? We need to calculate. If that is not there, then we have better to plan for the surgical removal or surgical extraction of your fractured tooth. So we have different mechanics for forced eruption. So in such cases, we need to, in the morning also, we consider some similar situations. For example, this incisor is placed like this. So you need to strap up your upper arch, place an open coil spring so that with the eruptive forces which is acting onto the incisor, you have a tendency of intrusive forces on the adjacent teeth. You have an intrusive forces on the adjacent teeth. They might tip mesially, they might tip close, they might close up. In order to avoid such situations, what we are supposed to do is we are supposed to put an open coil spring so that the space that is there for the central to erupt will be maintained. If the space is deficient, we need to put an active coil spring so that your space is also maintained, space is also open up. While at the time of opening the space, you have an traction in the downward direction, traction in the occlusal direction. If the deflection is too much, we can engage an elastics like this, or we can engage a ligature wire like this. If the deflection is less, we can attach a piggyback mechanics like continuous arch wire, base arch wire will be there. And a sectional night eye wire can be passed from the base arch wire above the bracket and then can pass here. Because of your shape memory of your night eye wires, your tooth will get erupted. So if you don't have a sufficient distance, for example, in second picture which you are showing, if you don't have a sufficient distance from the base arch wire to the tooth, what you are supposed to give an offset bends like this, so that you have a sufficient deflection, or elastomeric thread or elastic chain can be engaged for the eruption of your tooth. So many cases will come across such patients like adult patients where they have undergone extraction because of a badly carious tooth, or maybe because of lack of knowledge about the root canal treatment and restoration of procedures. For example, this patient underwent extraction long back of your second molar. So they didn't go for the replacement. What will happen? You don't have an opposing tooth for biting. So what will happen to the upper molar? You have a supra erupt. So later when they realized, so we need to go for the replacement of your prosthesis or an implant over here, so which is not possible because of your supra eruption of your opposing tooth. In such cases, what you're supposed to do, you're supposed to intrude. We're supposed to intrude the tooth. Intrusion can be done with the different mechanics. One mechanic which I have shown here, placement of your tats on the buccal side, placement of your tats on the palatal side, given elastics, either a continuous elastic from your buccal to palatal side, or attach a button over here, attach a lingual palatal also, attach a button over here, given intrusive mechanics for such teeth. This is a mousetrap appliance which can be taken support of your palatal region. So this is also helpful for the supra-erupted molars to intrude. So when you want to do an aligning mechanics in the anterior region simultaneously as well, you want to do an intrusive mechanics. You strap up your entire arch. When you strap up your entire arch, place in tats on the buccal side as well as on the palatal side, give an complete E-chain from your palatal to buccal side, so that intrusion mechanics will occur. So simultaneously, you check for the space, how much space is available. So when your oral surgeon or a prosthodontics is planning for an implant to place, if you think that the sufficient space is available, between your molar and the premolar, ask your surgeon or a prosthodontist to place the initial appointment of your implant. Initial placement, after placement of initial placement, they'll generally wait for 2.5 to 3 months time. During the meantime, you can go for the intrusive mechanics of your upper molar and uprighting of your second molar. So with this, you will save some time. For the second appointment where they place the superstructure and prosthesis. So what are the benefits of orthodontic therapy for a periodontally involved teeth? So we all know that which are crowded or malposed, there is a chances of there is a less chance of cleaning them properly because of overlapping of the teeth. Brushing will not be possible for such cases, and there's a chance of plaque accumulation and the tartar accumulation that region which are placed in a crowded position, and the gums will not be get clean and they get inflamed. So when you are aligning those crowded teeth or malposed teeth, they are better. They have a better access for the cleaning. The cleaning of all surfaces, labial as well as a lingual or a palatal surface, is possible. So vertical tooth, orthodontic tooth repositioning can be reduced. We can reduce the osseous defects in the periodontally patients. For example, in such cases where you have a bone loss is there, in such cases, vertical tooth movements like intrusion tooth movements can be carried out so that the bone support will improve and they become stabilized. The bone mobility or tooth mobility will get reduced. So orthodontic treatment can improve aesthetic relationship with maxillary gingiva and margin levels. So we have seen one slide in the morning session also how the maxillary gingival margin has to be positioned. We have central and canine relationship. Canine marginal gingiva should be in one level compared to the of your lateral teeth. So aligning those gingival margins orthodontically, as well as if we require anything periodontically, we need to correct them. So if you have an open gingival embrasures like this, patients will come. I want to get it reduced, this dark triangle. So your periodontist, generally they might be approaching a periodontist. They have a problem with the gums, which is not covering this triangular area. So what the periodontist has to do, they will not plan for any surgery for closing of this gap. So this may occur maybe because of your tooth anatomy, maybe because of your tooth inclination or whatever is it, or tooth morphology. In such cases, an orthodontist is a better option in relation with your periodontics rather for closing of such gaps. Just flatten these, do some interproximal reduction, taking the consideration of your enamel thickness, put a segmental mechanics and close the space. This definitely improve over a period of time. The black triangle will get disappear. So this is a brief about your adjunctive orthodontics, which we have covered many of the topics in the previous since morning. So any questions can be posted in the text box.
Yes, sir, we have a few questions from the last lectures as well, from this lecture also.
Yeah.
Many of the questions are already answered, so but few of them I'll read out. Dr. Yugal has asked Dr. Prasad sir that management of black triangles. I think that has been answered right now. So, sir, if you want to put some light on the management of black triangle by orthodontic approach.
Yeah, others, please mute. Only one person should speak. Hello.
Hello. Hello.
From Dr. Yugal Dubey.
Yeah.
So I want to ask a question to Dr. Prasad sir about a black triangle management of orthodontic approach. I think I have cleared this black triangle management, how it has to be done in the adjunctive orthodontics as well as in the perio management. So many times you need to see why this black triangle is been formed. Either it is because of your recession in the gingiva. If it is definitely your anatomy of your tooth is well maintained and your angulation of the tooth is good enough, then the black triangle has to be managed by a periodontist for repositioning of your gingiva. If it is because of your morphological deficient or morphological problem, then we need to think about orthodontic management for closure of the technique with the help of your segmental mechanics or a full arch mechanics. Is that clear?
It's clear. I think we have explained it in the topic lecture also. So moving on to the next question. So there is one more question. So is grade 1 mobility an absolute contraindication for orthodontic treatment?
Yeah, is grade 1 mobility is an absolute contraindication for orthodontic treatment. So this question is slightly tricky, but what type of tooth movement you want to carry out in the orthodontic tooth treatment, rather I can say. For example, if the patient is having a grade 1 mobility of your incisor and you are trying to extrude the tooth, the mobility will definitely increase. If such cases grade 1 mobility is there and you are trying to intrude the tooth, the mobility will definitely reduce. This is an indication for orthodontic treatment, so that the type of tooth movement is mainly plays an important role, whether it is grade 1 mobility or not. But generally with the grade 1 mobility, with the mild forces, we can carry out an orthodontic treatment. There is no absolute contraindication for such grade 1 mobility.
Thank you, sir. It's a well-framed answer. Dr. Trupti has a question for you, sir. What is the minimum bone level required for orthodontic alignment?
This is one good question. What is the minimum bone level required for orthodontic alignment? I came across many patients. I have a patient of 58 years also in my clinic. So at this age, the orthodontic treatment is possible or not? They have a doubt. So at my age, is it possible, sir? I'm already 58. So I said only one thing: age is not a criteria. We should have a good bone support. I recommend to have a full bone support up till the cervical margins, which is needed for a good alignment, good orthodontic tooth movement. In case you ask for the minimum bone support, 2/3 of your root has to be supported with the help of your bone. Then only we can carry out orthodontic procedure. If it is less than the 2/3 of the root, then orthodontic treatment will give a bad result. The mobility of the tooth might increase and the prognosis is not so good.
Thank you, sir. There is another question by Dr. Snigdha, and she wants to know that success rate of teeth alignment in pathologically migrated teeth.
Yeah, a success rate of your teeth alignment in pathologically migrated teeth is always good enough, unless until you remove what exactly is the pathological tooth migration is because of. For example, if you have a traumatic occlusion, you need to try to restore the traumatic occlusion first for before coming up to the teeth alignment. So when you try to do the traumatic teeth alignment, but you have a traumatic occlusion which is there, which is hitting the anterior teeth, then definitely there will not be any good prognosis for teeth which you align.
Thank you, sir. Next question is, I'll take up the question, last question, which was asked just now.
Regarding intubation, I guess.
Yeah, intubation, because Dr. Satish is again. So we'll take for Vilashan. Intubation is performed, how intubation is performed in both destruction and osteoporosis and
Okay. So in cases wherein we go for distraction, for example, if you take a case of a TMJ ankylosis patient, we want to go for distraction first without releasing the ankylosis, right? And even if you want to release the ankylosis, the patient is not having mouth opening. So in those situations, in initial days, the anesthetist, the experienced anesthetist, they used to go for a blind nasal intubation. They used to just blindly intubate by introducing a ET tube or an endotracheal tube through the nostril and blindly intubating it. But nowadays we are well equipped with a nasal endoscope. So with the help of an endoscope or a bronchoscopic assisted intubation can be performed, wherein it is attached to a camera. You can introduce the camera with through the nostril. You can see the carina, esophageal opening, your airway opening, and you can just pass on your endotracheal tube. This is one way. Tracheostomy was one of the way which was done, but again in initial days. Nowadays we don't go for tracheostomy. So this is one technique. And one more question was there regarding orthognathic. So in orthognathic cases, we would prefer a submental intubation. So in submental intubation, what is done is you introduce endotracheal tube orally and you remove it, the part which is attached to your anesthesia machine, that has to be brought out through your, one incision is given in the paramedian area, not directly into the mental area, but the paramental area. A small incision is given through which you take out the opening of the tube, and through that you can attach the circuit of your anesthesia machine through it. So that is a paramedian incision, and a mental incision is given, and you can go for that kind of intubation. So that won't interfere with your occlusion as well. Plus, when you are managing your maxilla, when you are managing your maxilla, you're giving your osteotomic cut, you're separating the nasal lining, it won't interfere in the nasal cavity as well. So submental intubation is one technique which is usually done for orthognathic cases. Hope that clears your doubt.
Thank you, Abhilasha ma'am. I'm sorry, Satish, we have to disturb you in between your patients. We can see you in your clinic. We have few questions for you also.
Yes, ma'am. Yes.
Dr. Sunil Agrawal wants to ask that if the patient is on antihypertensive drug during drugs causing gingival enlargement, when can we start his orthodontic treatment?
Hello, can you hear me?
Yes, you can. I can hear you.
If the patient is on antihypertensive, that too specifically the drugs which can create gingival enlargement like calcium channel blockers, most of the time which drug we find in our practice is amlodipine. It's the most common drug which we can see as an antihypertensive drug, and most of the amlodipine are supposed to be shown gingival enlargement tendency towards the gingival enlargement. So first of all, you need to treat the gingival enlargement. You have to go for a non-surgical, surgical therapy both. You need to change the antihypertensive medicine, because as soon as you place a brackets on the tooth, the gingival enlargement will come back. Why the gingival enlargement will come? Because the gingiva needs is just a bit stimuli for that. It doesn't happen that almost every time small amount of plaque can also cause a gingival enlargement. So when the drug is discontinued, not exactly discontinued, the drug is replaced. So we need to send a consent letter to the respective physician that this drug is causing gingival enlargement. Can you please replace the drug? Nowadays, many drugs like telmisartan is a very safe and very usually used as an antihypertensive. So it doesn't cause a gingival enlargement, and you can very well go the ortho treatment after the therapy and discontinuation of drug. Am I clear?
Yeah, okay. Thank you so much. Okay, there is one more question on which you have discussed already, but I want to read it out so that everyone can get the answer. Okay, there is a question by Dr. Amit Nasha, a young girl aged 18 to 22 with the bimaxillary protrusion diagnosis with mild to moderate periodontitis and minimum bone loss, horizontal, wants to get orthodontic treatment. All four premolar extraction was advised. Now, what should be the treatment plan? If full mouth flap is done, what criteria will decide to go for all four or not?
Exactly. So in this case, as you said, the patient is young and patient is suffering from mild periodontitis. So this periodontitis might not be aggressive. When you see the OPG, the horizontal bone loss, that too it's 1 mm, 2 mm, up to 3 mm horizontal bone loss is acceptable. And before starting the procedure, you have evaluated it, you have diagnosed that it has a mild periodontitis. You treat it first on a non-surgical basis, and then you can treat it on a surgical basis. So when you are going to treat it as a non-surgical basis, to go for a scaling, root planing, curettage, subgingival irrigation, and then when you assess the pocket depth, surgery, when you going for a surgery or not, it depends on your pocket depth. So when you take a pocket and probe it into take a probe and probe it into the pocket, you see there is a pocket depth of 4 to 5 mm, you need to go for surgery. But if after periodontal therapy, the pocket has been subsided by 2 to 3 mm, you don't need to go for surgery. You can go for a orthodontic therapy after maybe 3 months or 4 months. When you are sure that the periodontitis is arrested. That too is a light forces, because you cannot predict when the periodontitis will recur. So light continuous forces you can definitely start with, but you have to go for flap surgery. It is not necessary.
Okay, there is the last question I will take, and it is the last question, and it is I think for all of you. Dr. Sabha wants to know that how we can treat a reverse smile line
with an interdisciplinary approach. So I think Dr. Prasad Konda needs to get into the discussion. Reverse smile line using interdisciplinary approach.
Yeah, how can we treat a reverse smile line with interdisciplinary approach? This question is slightly vague, right? We don't know the clinical condition, how the smile is as of now. We have
it is incomplete question, I think.
Yeah, incomplete question. So we have a smile we can analyze as a consonant smile and a non-consonant smile. The curvature of your upper teeth should be along with the parallel to the line of your upper lip when the patient is smiling. So whether the patient is having a full set of teeth, that can be done with the help of your braces treatment. If the patient is having a partial like edentulous, in such cases, we need to align the teeth which are present, and we need to plan the processes. We need to plan the processes in the smile, maintaining the smile line. So in that way, we need to do an interdisciplinary approach along with the prosthesis as well as your orthodontics. Coming to your gum line, as I told you, we need to maintain the gum line of your incisors, central incisors, lateral incisors, and the canine, keeping in mind how the aesthetic has to look. So this is how we define. The question seems to be slightly incomplete to give a complete answer to Dr. Sabha.
If she's there, she might add something if she wants. Okay, so with this we come to the end of the question answer session. So over to you. Surbi, you are mute.
I would like to present as a token of appreciation certificate to Dr. Prasad sir. Kindly accept the certificate, sir. Now I request Dr. Megha Jain ma'am for vote of thanks. Over to you, ma'am.
Thank you, Surbi. The end of a story is the new beginning of many others. On this note, let us conclude a remarkable and knowledgeable event. It is a privilege and great honor for me to acknowledge and extend vote of thanks to all those who have contributed their part to make this webinar a success. On behalf of Department of Orthodontics and Dentofacial Orthopedics, CDCRI, I extend my heartfelt gratitude to the chairman of our institute, Dr. Shri Nemi Chand Parak sir, Vice Chairman Shri Sudhir Buddhan sir, Secretary Shri Sanjay Golcha sir, and all the esteemed directors. Their vision, interest, and enormous support has culminated yet another success story. My sincere gratitude to our Dean, Dr. Hema Suryavanshi ma'am, who is not only a great motivation for all of us, but she is a visionary and the person who gave us the belief to bring together this event. Thank you, ma'am, for your constant support and encouragement. I wish to extend my greatest and deepest gratitude to our esteemed speakers, Dr. Prasad Konda sir, Dr. Abhilasha Yadav ma'am, Dr. Satish Gupta sir, for accepting our request and sharing their knowledge and experiences. You all are exemplary dentists and great orators. We have learned a lot from you today. Thank you all once again. I would like to acknowledge all the distinguished guests, head of various departments and faculty members who have raised this occasion with their presence here today. A leader is someone who creates an event. Team members essentially brings life to it. Dr. Achin Chachada, head of the Department of Orthodontics, and his dedicated team members, Dr. Piyush Khandelwal, Dr. Tanusha Mahobia, Dr. Shruti Hatewar, Dr. Raj Bhagwatkar, Dr. Divya Mishra, Dr. Prateek Gaurav. They are the heart and soul of this event, bringing life and success to it. Please accept my deepest appreciation. Above and beyond, backbone of this event, postgraduates of Department of Orthodontics who went an extra mile, worked very hard and made this success story a reality. Thank you so much, guys. You deserve congratulations and appreciation for our job well done. And above all, I thank all the delegates. Your interest, enthusiasm is indeed a good sign for future. On behalf of organizing committee, I can assure you that in the coming years too, we will keep on organizing such events with some more innovative ideas to nourish your mind and fill you with more knowledge. Your suggestions and feedback are very much welcome. Thank you all once again. Have a great day. Thank you.
Thank you so much, ma'am. Now we have come to a sweet end of this program. I would request each and everybody who has participated in this program to kindly fill the feedback form. The link for the feedback form is already available in the chat box. Kindly fill and the certificates would be distributed within few days. Thank you for the patient listening, everybody.
Thank you, sir. Thank you, Satish. Thank you, Abhilasha ma'am.
Thank you,
Thank you
sir.
so much.
Thank you. Thank you.
Good day.
Thank you.